Do you hear me?
Hi everyone. Hi.
Yes.
Hello. Hi.
Hi,
Hello.
Hello.
Okay.
yes. Within 5 minutes, we are going to start the program. Yes. Yes, it's already 8:40. We can start the program, madam. Just let me introduce myself. My name is Madhu Bhupati, representing Inovine Meetings, LLC, to distinguished doctors, scientists, colleagues, friends, ladies and gentlemen. It's a great honor for me to welcome for joining this event, the World Nursing Education Summit that is going to happen today. Yesterday, we have successfully completed face-to-face meeting, that is October 16th. In our last results, I would like to express my most sincere gratitude for your presence in this opening ceremony as the gateway to initiate our program. And especially thanks to Mr. Henry Bruce, who have shown his heavy burdens, duties, and responsibilities to make this event happen today. I would also like to thank participants, especially those who are joining from miles, for joining and sharing your valuable experience and ideas. With a good number of participants, I'm sure this conference will be memorable, highly educational, and fast-paced event. So thank you so much for joining this event. Yesterday, we have successfully completed a face-to-face meeting with a different topics with different sessions. Today, we are going to join with Zoom meeting. I request to everybody to keep mute yourself when others are speaking, mute yourself when not speaking, turn your video, notify others when you want to speak. And the other question is very important. If you have any kind of questions or comments, you can text in chat box. Or else, if you are unable to submit PowerPoint presentation, we ask you to submit into the following email ID, that is innovineconferences@gmail.com. So let me introduce the first speaker of the event, Dr. V. Esposito Kumbanago from York College, City University of New York from USA. The title will be Service Dog SD versus Emotional Support Annual, ESA. Yes, madam, you can start sharing your slide.
Okay, thank you. I'm going to share the screen now. You can share. It says all participants. Okay.
Yes, we are unable to hear your voice.
I see it. Okay, great.
Fine.
All right. Good morning or good afternoon, depending on where you are in the country. My name is Dr. Esposito Kubanek, and I'm an assistant professor of nursing for City University of New York. So one of my passions in my service for my school is service dogs and emotional support dogs. I'm also board certified in psychiatry and mental health, so it's important in that field as well. So today I'm just going to talk about service dogs versus emotional support animals. I know we've been seeing a lot of these lately, especially since COVID, but there is a distinct difference, and there is a difference how they're used in healthcare as well. So I start with a little theory. Florence Nightingale has been quoted in her notes on nursing from the 1800s, saying a small pet is often an excellent companion for the sick, for long chronic cases especially. So it's been noted really as far back as man, service dogs, emotional support animals, the unsung secret clinicians, as I like to speak about these animals. So animals have long shared the earth with man. Dogs represent humanity's oldest friend. There's unconditional love. They're the perfect partner. The social bonds between a man and a dog, a human and a dog, is extremely strong. And this supersedes any other animal. So it does lend itself perfectly for training dogs for life-saving tasks. Which brings us to the service dog. So the definition really of a service dog is service dog allows an individual to carry out daily functionings despite having a disability. These dogs are trained specifically for a task for that one owner, that or handler, whichever way you call it, whatever their need is. And you see the picture is, seeing eye dog, which is very common. There are other tasks that these dogs perform as well. But the Americans with Disabilities Act is a federal law in the United States, and it protects the service dogs and allows these dogs to perform these tasks that would otherwise stop this individual from really capability of their fully functioned life. So they're protected by the federal government. So what does that mean? This is just a little piece of the Americans with Disabilities Act, their website. You could look. I took out two titles. Titles 2 and 3 says the only animal that's recognized to perform this life-saving task is a dog. Okay. And under the Title 2 and 3, individuals and places have to allow the service dog entrance. So that means these dogs can go anywhere people can go, whether it's private or public, airplanes, hospitals, restaurants. The dogs are federally protected because without them, the person could not fully function. So functional impairment could be from chronic diseases. They help strengthen people's quality of life. These highly trained dogs, they do that task so that people can live their life. Some tasks, like I said earlier, seeing eye dog, but they're trained for many things. Alerting deaf people. They have dogs. I used to have one too, trained for diabetes. They could smell the highs and lows of sugar. For seizures, they can sense the seizure coming on and assist their handler, their owner, to the ground for safety, get their medication. Unsteady gait. I mean, there's a myriad of things that these dogs are trained tasks to do. According to Rodriguez, there has been a therapeutic value reported in the use of service dogs for mental health as well, especially in depression, anxiety, and PTSD. It was really started mostly used in the military personnel, but now that has taken off to lay people. So service dogs provide a life-saving task for one owner. They're trained specifically for that task. Whereas emotional support animals, which we're seeing a lot more of now, is a whole different classification. So an emotional support animal can be any animal, literally any animal. It can be a cow, a chicken, a rabbit. It doesn't matter what the animal is. Their sole purpose is to provide a therapeutic benefit from the companionship. So they're not really trained in one specific task, but their company provides a emotional support, hence the name, and provides comfort to not just one person, but could be many people. I happen to have an ESA that I bring to hospitals and to schools, and he visits classrooms, teachers, children with disabilities, inpatient, critical care patients. It can be used, these animals can be used really much anywhere. They undergo special training to provide that comfort. And there is a lot of therapeutic use in healthcare that they use. Healthcare providers I personally know have used emotional support animals during therapeutic sessions with patients, during family visits. A lot of benefit to that. They can use them, as I mentioned, where I went, but also palliative care, hospice care, nursing homes have emotional support animals. Again, it could be a goat, could be a rabbit. It doesn't really matter. It could be a dog as well. They provide their owners with that companionship and can benefit multitude of people. Generally, they are not protected under the ADA. So that's the distinction. So if you work in a hospital, you must allow a service dog entrance to your hospital because they're federally protected in the United States. However, an emotional support animal are not protected at all. They're not recognized. Here is, that's actually me with Rex. He is a service dog and an emotional support animal. On the right, he's going into the hospital to palliative care. On the left, he's visiting college students before a final exam, to decrease anxiety. All right. Behavioral health has definitely been studies. Behavioral health have used both ESAs and SDs by healthcare providers to augment treatment plans because of the powerful bond between animals, dogs, and humans. That relationship is super easy. Routine visits are also very well received. Therapeutic communication flows effortlessly between healthcare providers when there is an emotional support animal or dog at the bedside. Here is Rex again. At behavioral health, these are not patients. On the right, actually, he was visiting medical students who were having a particularly stressful day. They called and asked if he could visit. And on the left is some staff members and volunteers, but this is the area, the garden area, where he would visit the patients that are inpatient behavioral health and drug addicted units. Very successful. They look forward to his visits. Unknown author once said, to err is human, to forgive is canine, and it really is evident, especially in behavioral health. Okay, so animals have been progressive role in the treatment for a diverse number of psychiatric disorders. The benefit of healthcare providers collaborating with this animal-assisted therapy, especially with children and elderly, like I mentioned, nursing homes, psychotherapy sessions, definitely been documented. Winkle et al. Specifically did note and did some studies on the treatment of autistic patients with service dogs. And it was very useful to decrease the patient's anxiety, but also in autism, there's that social, they have a social anxiety, but their social anxiety actually went up. They were able, not the anxiety went down, but they were able to interact more socially outside of the home, the autistic adolescents, when they had the dog at their side. So that was pretty amazing. That was by Winkle. And here he is again, many different places he goes. On the right, he was distributing gifts for orphans, and on the left, he was visiting the physical therapy department. So it's not just patients. I get a lot of calls for him to visit staff, different staff in the hospital when they have different crises or things happen with their patients. They're very stressed out. I get a call, I bring them in. Okay, so positive outcomes, future plans. There's definitely data that points to the positive outcomes using dogs in healthcare, particularly behavioral health. So I believe proper creativity, the possibilities really are limitless. The need for the treatment exists. Healthcare providers really are always looking for new modalities of treatment. Dogs are always willing to love and serve. So this is like a great combination. And here he is again visiting on Nurses Week. These are nurses. It was a special treat for Nurses Week at this hospital. We were called in to visit the nurses and say thank you. He handed out gifts to the nurses. It was kind of cool. Okay, so quick recap. Service dog can only be a dog. Only a dog can provide a task for a disabled owner, and they are federally protected in the United States. An ESA can be any animal. They provide emotional support for many patients through companionship. Healthcare providers use both types of animals in animal-assisted therapy. There is definitely therapeutic value documented in many inpatient and outpatient settings. Future research definitely is also limitless because there are so many different specialties that are now using animal-assisted therapy more than so in the last even 10 years. These are some references that were on these slides. Also the website for the ADA, if anybody wanted to look up the actual law. It's good to know if you are a healthcare provider to know that law in case someone does show up with a dog. And thank you for listening. This is a quote: "A dog is the only thing on earth that loves you more than himself," which is so evident if you've ever seen animal-assisted therapy. The other thing is, if you see a dog with a service vest, and you're not allowed to ask the person what their disability is because that would be a violation, but you are allowed to ask, what do they do? Just in case it's something that would interfere with wherever you are. The only time you can ever ask someone to leave that has a dog is if obviously if the dog tries to bite someone, but usually they go through such intense training that their personalities are super, super docile. Anyway, that's it. Thanks so much. Any questions? I don't know if there was anything in the chat. Okay, that was me. I can't hear you though. You have the you're muted. You have to unmute yourself.
Yes.
Sorry.
Thank you. If you have any questions related to this topic, just you can raise your hand.
Okay, well, I'm gonna drop my email into the chat, and if anybody ever has any questions about it, feel free to let me know.
Yes.
Because I do a lot of work in this.
Yes, it's better. It's better.
Okay,
Yes,
thank you.
thank you so much, madam. Thank you so much. I hope we expect your presence for next year in
Yes.
face-to-face meeting.
Absolutely. Okay, thank you.
Yes, you'll be getting the participant certificate as well, booklet within a couple of days.
Okay, thank you.
Thank you so much, ma'am. Next, we ask the first keynote speaker of the day, Dr. Florence Cantil, President Hong Kong Nursing Association from UK. The title will be launching a new training program in the supporting the buddy scheme for Hong Kong healthcare professionals in London. Yes, thank you so much, madam.
Let's see whether I can get the screen up. It's gone. my slide's gone. Let me see whether I can get it back.
Yes.
Sorry about that.
No problem.
Let's see whether I can get onto that for us. Now I can't really get onto the screen.
So do one thing, madam. Just do one thing. You can share your you can share your PPT in the chat box. I'll be playing behalf of you.
Can I share like that?
In the bottom of the screen, you can find share screen
Hang on.
with yellow with green color.
Hang on. There.
Yes, it's fine.
Can you see that now?
Yes, it's fine.
Okay. Let me see. I can't really. Okay. Did you see one slide or everything?
Yes, we are on the first slide.
First slide. Yeah.
Yes.
Yeah. Okay. Can you see on the side as well? Where my other slides are? No. Okay. Okay. If that's okay. Okay.
Just you can click on the slideshow, madam. On the top of the website, you can find the slideshow. Slideshow.
Yeah, that's true. Yeah. Hang on. See if I can.
From yes. From the beginning.
From the beginning. This is the from the beginning, yeah.
Yes.
Can you see it all right? Can you get it?
Just click from the beginning. Okay, no problem.
I did click it, but it doesn't really seem to work.
Okay.
How interesting. No, that is not right either. What do I do now? I can't get it work.
Okay, no problem. You know, we can see your slide on first slide. You can click on the first slide. You can introduce yourself and start presenting.
Okay. Okay. I could go to one slide after another. Is that okay? Yeah. Yeah. Okay. So many thanks for the invitation to speak at this conference. So my name is Florence Cantil. I'm speaking in my capacity as President of Hong Kong Nursing Association, UK. Before I get going, I want to give you a disclaimer. Throughout my talk, I'm not speaking as a representative from an NHS organization in the UK, and hope this is okay with you. So now I'm going into the main part of my talk. The areas that I would like to cover, then overview of the UK health service model, NHS health service in England, and then I will talk a bit about on the NHS workforce in London, and then also an overview of Hong Kong Nursing Association UK, and the work that we did in 2021 on the Hong Kong Resource Pack. And then the work we're doing right now on the project That's the buddy and mentoring scheme that we launched in August this year. And then we talked about the progress we have made so far, and also the future plans for of activities before the funding actually ends in January next year. So what's the healthcare system then? So NHS began in 1948, and services are free to patients at the point of use, funded through general taxation. Excuse me, can you mute
Yes,
yourself, please? So the GP or the family doctor that we see in general practice is the gatekeeper to the healthcare system. So broadly speaking, patients are actually given some choice to pick the local hospital for their care closer to where they live. So NHS thrives for clinical excellence and uses the significant biomedical science research infrastructure to improve and innovate. And in the pandemic, the joined up nature and of the NHS enabled rapid testing and also evaluation of treatment options. So certainly we have world-class health service in London and also other parts of the country. So the budget for NHS to buy services from hospitals, community healthcare services, and also primary care services and public health services. I'm sure that you know about the national screening program that we have in the UK, particular bowel cancer, cervical screening, and also breast cancer screening as well. So anyway, the commissioning budget for the NHS England is around £156 billion. That's actually in 2022-23 to cover over 56 million people living in England. So secondary care, which is sometimes referred to as hospital and community care, can either be planned care or urgent and emergency care. I'm sure that really similar to United States healthcare. Tertiary care, we cover very specialized treatment such as neurosurgery, for example, transplants, and secure forensic mental health services. There's also other non-NHS organizations providing healthcare services to people. It can be independent sector and also some charity organization as well. So over 1.4 million people are actually employed in NHS. That is way back in November 2022, which makes the NHS one of the world's largest workforce in the world, and is made up of 500 organizations, different organizations in England alone. And we are the 8th biggest employer in the world, and NHS England is the world's 17th largest employer. So let me get to the next slide. So NHS England established 42 integrated care systems under the Health and Care Act 2022. In this map of London, NHS London region has 5 integrated care systems. An integrated care system, may I say, is a statutory partnership of all organizations who plan, buy, and provide health and care services in the geographical area. Normally covers around 500,000 population in each integrated care organization. So they work together, improve quality of care, efficiency, and also outcomes for patient care. So London has the second largest population of the 7 regions in England, with 8.8 million resident population. So in terms of NHS workforce in England, it is actually estimated that there are over 124,000 doctors and 300,000 nurses working in the NHS. So in London, over 235,000 NHS workforce in London, with 29% of nurses and midwives. And 58% of the NHS workforce in London are from Black and ethnic minority groups, and I'm the one of them. And 20% of workforce in London come from the rest of the world. So I just want to skip the next 2 slides, because otherwise, you know, you've got other speakers lined up. So the next slide that I would like to show you is really about the Hong Kong Nursing Association UK, where I come from. So Hong Kong Nursing Association UK is a professional organization for Hong Kong nurses in the UK. So our aims are to connect all the nurses in Hong Kong, from Hong Kong, and build a community between ourselves, and also help each other for a happier life in the UK. When we also provide information and support to those who are planning to continue their career in the UK. So we actually build a very strong network with NHS, hospitals, and caring organizations in the UK. So we're trying really hard, or trying our best, to help nurses who have just arrived in the UK for getting jobs and to settle happily in this country. So how many nurses we have in the UK? We have 289 Hong Kong nurses and midwives on the Nursing and Midwifery Council register. But surprisingly, there are over 800 Hong Kong trained nurses still on the NMC registration process, with various reasons why they can't actually get the registration. And I mean, I can actually tell you later, but we are doing our best to support, you know, Hong Kong nurses to get the registration and also, you know, getting a job if they want us to support them. So next thing that I would like to mention is the Hong Kong Resource Pack. Just to really tell you that, you know, one of the key achievements that we have made. So in 2021, we actually worked collaboratively with NHS England and Hong Kong, welcoming Hong Kong Hub at each strategic partnership, migration partnership region. They're actually really from led by the central government. So it's all really involved all the local councils and local governments, you know, in working together. So we actually create one single resource pack for Hong Kong nurses. We really would like to provide guidance and information to Hong Kong nurses who really need the information to help them to do, to get the job, and also, you know, how to actually live in this country, what are the things that, you know, they can actually find in terms of local amenities, local social groups and activities, and how they actually, you know, connect with the local communities. So anyhow, the pack actually covers a various of things, and I would like you, you know, to contact me if you would like a copy of it. So it is really something that, you know, we're really proud of ourselves that we work on. So now I really would like to talk to you about, you know, the funded project we're leading in London. So this is the buddy and mentoring scheme in London, and it is actually funded by Greater London Authority. We were so thankful to them. So we are actually aim to invite a lot of healthcare professionals in London to support us. So of course, you know, the selected number that we want to recruit. So this project was actually started in August, and we are actually on track with our project milestones. So we completed a set of training for mentors, and I'm going to mention to you in a minute. And once the mentors and mentees are matched, they are actually go on to start their first mentoring session. By now, I'm sure that, you know, they already started because, you know, we're now in October. So ongoing supervision and continued support are provided to mentors and mentees as well. So let me skip to something that I would like to talk to you about. So this is the first session that we actually running as part of the training, a series of training sessions. So this is really something that we feel as if is important to raise the awareness of mental health conditions and how to promote mental well-being through offering appropriate resources, materials, and guidance from the mentors to the mentees. So we actually, you know, have a set of slides to provide the mentors following the session. So that is one thing. And the second session is very interesting, is on fitness, yoga, and relaxation. So we focus on that in person. We invite the mentors and mentees as well to join us at a gym studio in London. So this really helps us to understand the importance of self-care and self-management, and having the opportunities for everybody while they're in person, while they're at the gym, to connect each other and to link in with others as well. So that is what is really, really helpful. You know, we have a excellent fitness instructor there, and everybody really enjoyed the session. And after the session, we actually went out, you know, to nearby Thai restaurant, you know, have a chat over the lunch. So it's really, really good. So the last session that on the training is about we are going to introduce what actually mentoring is all about. So let me go into this one. This might be more interesting. So really, this session was delivered by Befriending Networks, which is a non-profitable organization. I was so pleased that, you know, we have them. So what they are doing is that, you know, to cover a number of key areas. What is mentoring? The role of mentor, and how we can have a positive impact on others, and how to establish and respect boundaries. So just really briefly talk about what is mentoring. So having worked as a mentor to a lot of healthcare professionals, both from statutory and voluntary sector over the past 20 years, I agree to the definition of mentoring in this slide. It is about coming together. It's a beginning. Keeping together is a progress, and working together is a success. So I don't want to take up too much of your time, but anyway, this is another interesting slide to me. So there are 6 C's of mentoring, 6 C's of nursing, and 7 C's of resilience. If you ask me which 2 C's in each category values me most, I will say connection and communication. in mentoring, commitment and compassion in nursing, and confidence and coping in resilience. And I'm not going to ask you as the audience what your answers are, and I'm sure that you can tell me later. So this is another interesting slide. Most of us have had a mentor and have made a positive difference in our lives. And many of us must have worn different hats, and some of you may follow our learning from mentors within television, film, and literature. So can you recognize any of the characters here? I'm sure you do. But to me, the mentor is missing here for me. It is my dear mum. So anyway, I think I would like to say the last thing. I think it's my last slide now. I know that we're running out of time. So I hope that it's okay with you so far. So finally, here are the forthcoming events for the mentors and the mentees in October, this month, and November. It's just to offer them ongoing support and supervision during the mentoring period. So I don't really want, that means it's on the screen anyway. So many thanks for listening to me, and we wish you all well with your nursing profession, and we need to grow together. We need to learn from each other, and we need to help and support each other. So I'm going to finish by saying a big thank you to the 9th of World Nursing Education Summit for having me. And thank you ever so much for your attention, and have a great conference. Thank you.
Yes, thank you. Thank you so much, madam, for joining this event. You are supposed to be in face-to-face meeting yesterday. No problem. We have received your talk today, and you'll be getting the participation certificate as well as booklet within a couple of days. Hope we expect your presence for next year in face-to-face meeting.
Thank you so much for having me.
Yeah. Yes. Thank you so much.
Any questions from anyone, or I'm sure that
Yes.
you will...
Yes. Any questions regarding this topic? Any questions? If you have any questions regarding this topic, you can text in chat box. We'll be asking you behalf of you, even after the completion of the Congress.
Okay, I sounds as if everybody is happy with my presentation, and thank you so much again for having me, and hope to see you all very soon.
Thank you so much, ma'am. Thank you so much.
Yeah.
Have a nice day.
Okay, have a nice day. Bye-bye now.
Yes. Next, we'll go with Dr. K.M. Yakub Mathai, the Marma Healthcare Center, Kerala from India. The topic will be the definition, diagnosis, and treatment of fever are against modern science in the world today, and why. Yes, sir.
Hello.
You can go ahead. Yes, sir. You can go ahead. by
Hello,
sharing
I
your
want
slide.
to share my screen.
Yes.
Yes.
If you are ready, you can start sharing, sir, or else we'll go with
Yes,
alternate.
it's okay. I am ready.
Yes, go ahead.
One second.
Next, we ask Dr. N. Gayatri Priya to get ready with PPT. Dr. Epsam Abu Ashish from Alexandria University from Egypt. Dr. Asta Mongelio from Public Health Expert from Cameroon. Yes, madam, you can go start sharing your slide. You can introduce yourself and go start sharing. Yes, madam, you can start sharing the slide. It's okay, fine to us.
Okay, did you hear me?
Yes, yes, it's fine.
Okay. Welcome everyone. I am Dr. Ibtisam Abu Hashish, a professor of nursing management and leadership. I have two affiliations. The first affiliation of Alexandria University, Egypt, and second affiliation is King Abdulaziz University for Health Science, Saudi Arabia. Today, I will present my topic about brain drain. Determinant and mitigating factor of brain drain among nurses, a mixed method study. Just want to make sure that the slide is run up because it's not move in front of me.
Yes. You can start sharing from slideshow, madam. You can click on the slideshow. On the bottom, you can find animation slideshow. You can click on the slideshow.
Slideshow.
Yes.
Where exactly? I can see record, show captions, reaction setting.
You can go on the first slide, home, insert,
So-
draw, design, animation, slideshow.
From where? I can't see. Okay, do you see now?
Yes, it's fine.
Okay, so my article or my published paper today is about determinants and mitigating factor of brain drain among nurses. It's a mixed method study conducted at Egypt. So our table of content is about the introduction, methodology, result and analysis, and finally we'll end up with conclusion and recommendation. So let us to take about the brain drain phenomena. So what is brain drain? It's meaning a loss of trained professional personnel to another company or nations that offer greater opportunity. It's also known as a human capital flight. Scientifically, brain drain is a migration of employees in quest of an improved level of living condition, better earning, access to advanced technology, and a secured political condition in diverse places worldwide. Also, brain drain of nurses is an ongoing phenomenon, impacting the quality and the quantity of nursing workforce and affecting the quality of care. Nurses' brain drain, commonly known as a result of interplay of many factors. These factors identified as a push-pull factor model. The push factor refers to the national condition within source countries that have forced many nurses to leave the country. So it's called the place of origin country. These factors include the economic reason, the social reasons, the political reason, the health system, the professional, and the work-related reasons that push the nurses to leave their country. On the other hand, there is a pull factor in the country of destination that display the characteristics in beneficiary countries and might attract the nurses. These positive factors include social positive factor, family factor, career and professional development opportunities, positive work environment, job security, increased wages, and other associated benefit. And as you see in this figure, this is called a migration trend or the relationship between the push factor and, on the other hand, the pull factor. So why is this study? Because there is a gap in our knowledge as a researcher of how nurses perceive their work condition and what factors could aggravate their potential or intention to migration. Hence, there is a significant need to examine, understand, and identify how to mitigate all these factors that may contribute to potential or actual nurses migration and affect the quality of healthcare services provided in the place of origin or the original country. Up to the knowledge of the current researcher, when they conducted this study, there is no study had been carried out to explore what are the factors that might provoke a brain drain among Egyptian nurses. A compelling prospect of this research might lie in using a mixed method research approach. Within this approach, the researcher endeavored to understand the nurses' experience of reasons and factors could make Egyptian nurses likely to migrate in searching for employment. Also explore what strategies nurses suggest for mitigating the effect of brain drain phenomena, which expected to be more authentic and valid when integrating their perspective. So, the main aim of this study was to investigate the determinants, the push-pull factor of nurses' brain drain, and what are the mitigating factors from nurses' perspective using a mixed method study design. Moving to the methodology, this study was conducted at the main university hospital, which is a large university hospital in Alexandria Governorate or Alexandria city in Egypt. A mixed method research design using concurrent triangulation was conducted in this study, in which both quantitative and qualitative data were concurrently collected as shown in this figure. So the qualitative study part were carried out with a cross-sectional, quantitative study part was carried out with a cross-sectional design, while the qualitative investigation was guided by the semi-structured interview to elicit more insight of nurses' personal experiences and understanding of their potential factor to migrate causing brain drains and how to manage. For the sampling, and for the quantitative part, all nurses with experience of 1 year at least and more were eligible for the study as an inclusion criterion. And for the qualitative part, we interviewed about 35 nurses on a purposeful sample until data saturation was reached. Participants of purposeful sample were also drawn from the quantitative sample. For collecting the quantitative data, we developed a brain drain questionnaire which included 3 sections. The first section concerned with the demographic characteristics of the nurses. The second section included 30 reasons for push factor for covering the social, the economic, the political, the health system quality, the professional, and the work-related reasons that push the nurses to leave their country. And the third section included about 29 pull factors, including social and family, career development, work environment and job security, managerial support, and the salary and the related benefits that identified the factors that pulled the other nurses to or attracted the other nurses to work in another country. The responses on this questionnaire was measuring using a 5-point Likert scale from strongly agree to strongly disagree. For collecting the qualitative data, we conducted face-to-face semi-structured interview with a developed guide based on 3 central questions. We asked the nurses 3 questions. The first one, in your opinion, what reasons are present in the Egyptian workplace that would increase the desire and the potential of staff nurses to migrate or working in another country? The second question, what are the workplace factors present in the foreigner countries that attract nurses to migrate? The third question, what are the measures can be put in place to stem or prevent nurses' brain drain in Egypt or other countries? All the methodological consideration regarding the RP approval, the ethical consideration, the validity and the reliability of the questionnaire, as well as the study guide, the official approval from the hospital. Also, we conducted a pilot study for both qualitative and the quantitative part. After that, we started collecting the data and the analysis for both quantitative and the qualitative data simultaneously. We also consider all the criteria of academic rigor, including the credibility of the finding, the dependability of the finding, the conformability, and the transferability of the data required in the qualitative part. Moving to the result section or the main result of this study, as shown in this figure, that there is a positive significant correlation between both factors representing push factor and pull factor, and both factors are contribute to the prediction of the brain drain phenomena among the nurses. When we asked the nurses' perception about the push factor of the brain drain, we found that economic reason with a major factor that push the nurses to leave the country, followed by the social reason, while political reasons, the lowest one. Moving to the pull factor of brain drain, we found that salary and related benefit in the other country can mitigate or can attract the nurses to work on their environment, followed by managerial support, while the lowest factor that could attract the nurses to work abroad is the work environment and the job security. Moving to the qualitative data, we found an interesting data. About 7 themes emerged from the qualitative data analysis. We found that economic factor, work environment and related factor, skill and career development, political issues, nursing image and power differences, personal ambition, and finally mitigating factor as the major theme derived from the qualitative finding, which support our quantitative finding. And this table shows for you the major themes that emerged from the qualitative data and their related categories, either push factor or pull factor or both push and pull factor, with the 20 sub-factors that representing these themes. The final question, which asked about the mitigating factor and how to prevent the brain drain phenomena among the nurses, nurses identified 5 strategies that could help to retain the nurses in the place of origin or the original country, including shared governance and participative decision-making with the nurses and involvement in the decision-making process of the nursing unit or the hospital, including the nurses in developing their nursing policies, rules, and regulation, improve their qualification and their skill and the development of professional and soft skills, including training and education, and involvement in the nursing governance of the country through the syndicate rule and positive marketing of the nursing profession. And I think these strategies apply to each country worldwide. This slide shows a sample of quotation from the nurses' responses to the qualitative data. For example, my husband couldn't understand the difficult nature of my role and arguing me about night shift, but I had no alternative to look after my kids. It's frustrating me as he should value my job. All of the people ought to honor this field. I was just divorced, but I'm much happier now. This is participant number 23. Another participant reported, I didn't inform neighbor with my job because of all the public image or idea of nursing in our Arabian countries. Another one, we perceive the power difference between physician and the nurses with underestimation of our practice or opinion in addition to the non-involvement in the treatment plan. Really, I feel powerless and my identity is abstract as a result of bad image and being undervalued. Another participant, I hope to find a suitable opportunity to migrate. Although I look for better living standard and I wanted to travel for religious purpose, I think that Saudi Arabia is the best choice for me to perform Hajj and Umrah. And the final quotation, I love traveling and I'm curious about new places and the culture. This is an example of the factors that push or pull nurses to work abroad. This slide already presents all the findings that we identified in our study, either quantitative or qualitative. And finally, we could present the push factor as economic reason, social reason, political reason, quality of health system, professional reason, work-related reason, and we add bad nursing image from the qualitative finding. For the pull factor, we found the salary and the related benefit, social and the family factor, work environment, professional and career development, management support, personal ambition, which already derived from the qualitative, in addition to the political and economic stability. And this is called the determinant of brain drain. On the other hand, we found the solution that emerged from our qualitative study, that workplace retention strategy, shared governance of nurses, participative decision-making, training and education, participation in nursing syndicate rule or other governance of nursing in the country, involvement in developing the nursing policies and laws and regulation, and the marketing the profession as a mitigating factor. So these factors could be applicable to devise another or a modified form of the brain drain questionnaire if you wanted to ask about what are the factors that causing brain drain and what are the solution for mitigating the brain drain. So, in conclusion, the positive side in this study is that this study supported the influence of common pull and push factor for nurses migration and caused nurses brain drain. Although economic factors are the most reported, they are not the only reason for brain drain, as the nurses suggest. But the negative aspect in this study is that with integrating both quantitative and qualitative finding in the current study, they saw that they face several challenges which pose them to think for migration or leave Egypt. The push factor, the interviewed nurses seem to be dissatisfied with the nursing representation in their healthcare system. So we have a certain implication in this study. First of all, we recommend for internal strengthening of the nursing sector through improving their condition, provide a solution to key problem arising from nurses shortage and poor condition. The other non-remuneration or non-financial strategies were recommended to retain nurses in their workplace, such as using a supportive environment, decision-making power, professional nursing governance, and the continual professional development program to retain nurses. Also, the nurse leader have a significant role in creating empowering and healthy work environment and supportive peer relationship. Professional marketing for better nursing image should be vested through public, social, and mass media with adequate recognition of nurses' role in the healthcare system. For future research implication, we call for a deeper perspective on brain drain among the nursing population. Future studies should employ sample of administrators and the nurses from different health sectors rather than university only. Also, the newly emerged theme from the qualitative data analysis, such as nursing image, personal ambition, and the mitigating factors should be used to refine the developed brain drain questionnaire and retest it in the future study. Professional intervention like workshop and training program for strengthening nurses' autonomy, governance, and leadership are essential and should be supported by evaluation to investigate its significance in producing a difference among the nurses. The key point for policy practice and research in our study, finally, brain drain of nurses is an ongoing phenomenon that will not stop and have impacted the quality of care. Nurses' brain drain as a result of interplay of many push-pull factors and mainly influenced by economic reasons. Retention strategy and the shared governance are important mitigating factors for nurses' brain drain in the workplace, and the nursing syndicate and the governance should have an active role in advocating nurses' rights and regulation and improving nurses' image. And this is our published study, determine and mitigating factor of brain drain among Egyptian nurses using a mixed method study. It already published in 2020 in Journal of Research in Nursing, SAGE publication. This is a sample of our references, and this is my personal contact if you want. Thank you.
Yes. This was a presentation from Dr. Epsom. Any questions related to this topic? We came to know Dr. Asna asked the question. Thank you for this very important study. My question is, who was the target of this study? Question mark. The nurse who works in the country Egypt, or those who have been or intended to migrate, or one reason or another? Can we have this presentation, please?
Okay, thank you, Mrs. Asta, for asking this important question. The target population was the Egyptian nurses, because already we target the Egyptian nurses and to find what are the factors that push these nurses to migrate out from Egypt and searching for another opportunity in the other country.
Yes.
Okay, for the presentation, I will share with you, inshallah.
Thank you, Dr. Ali, and for the answer as well. That is this is a very, very, very useful and very important presentation. And as African country, we are facing really a brain drain of nursing. I am an example of brain drain from my country, because I'm now in Brazzaville, but I'm Cameroonian. So it is very, very important. It is better. It is also good to extend this study in other part of the country or other countries in Africa. I really appreciate it, and thank you for sharing the presentation when possible. Thank you very much.
Thank you, dear.
Yes.
Welcome.
Thank you so much, madam, for joining this event. And you'll be getting the participation certificate within a couple of days. Thank you so much once again. Yes. Next, we asked Dr. K.M. Jacob from Marma Health Center from Kerala, from India. The topic will be the definition, diagnosis, and treatment of fever or against modern science in the world today. And the question mark is why. Sir, you can start sharing your slide if you are ready with PPT.
I am ready. I want to share my screen. Where is the screen share screen option?
Just to be honest.
Start a recording casting with the Zoom. Start how? There are no phone, so I am not familiar with this phone.
You can find in the bottom of the screen, you can find with this share screen with green color. You can start
Yeah,
sharing your
I saw that is a screen. Then after that share screen, I saw the share screen button. Then Microsoft OneDrive, Microsoft SharePoint, and Google Drive, and bots, and photo, document, and web URL, screen, camera, share, whiteboard, etc. Which I want to.
You can have the share screen with yellow color.
Yes, already I
Sorry,
saw
with green
This
color. You can
no.
find before chat box, you can find a share screen with green color. You can start sharing from there. Or
I
else
saw the not a green color, but I saw the share screen. This no phone.
we'll go with auto
Microsoft.
speaker. Sir, meanwhile, you can submit your PPT to me, sir. I'll be sharing from here.
So one second.
You can text in, you can send in WhatsApp number. So we'll go with alternate speaker. So now I request Dr. Ian Gayatri Priya, College of Health Sports from University of Bahrain to start presenting.
Yes. Good evening, sir. Good evening. Thank you so much for the introduction. And just a minute, I'll just start share the screen so that I can be ready. 1 second.
I request everybody, if you are unable to share your PowerPoint presentation, you can mail us.
Just a minute. Just a minute. Just I'm
Yeah.
trying to share it.
Okay, no problem. Yeah, it's fine.
I hope everybody can see my slides, right?
Yes.
Yes. So here, good evening to all of you. And thank you for the opportunity given to present my paper in the 9th International Conference on Nursing Education and Healthcare. And thank you so much for the organizers giving the opportunity. Let me start my presentations with the background. Yeah. So as we all know, breastfeeding is intrinsic to the humans, and it is directly influenced by economical, social, and cultural aspects passed down to generations. So here it is the generation, it is passed in generations through the female focus. So the generations, whatever the experiences, the knowledge, the belief, the practices, whatever they have, it passes through the female generations. So grandmothers are significant figures for transferring the information and experiences who influence the mother's breastfeeding decision. So here my topic is mainly focusing on the grandmother's perception towards the breastfeeding practices. Yeah. So postpartum period, the grandmothers often spend more time with their daughters daughter-in-laws, providing emotional and financial support, taking care of the mother, the baby, and older children, and helping with household chores. So that's why the grandmothers will take up the upper role, the upper role to take care of the entire the period of the postpartum period, irrespective of the primary or the multi-gravid mothers. So they are the main influencing key factor to make decisions, mainly the decisions during the postpartum period. So grandmother's participation is vital in the construction of the breastfeeding process, whether to initiate the breastfeeding, not initiate the breastfeeding, or to replace the breastfeeding with some other substances, what the cultural practice within their focus. So within the background, the statement of the problem goes like this: a qualitative study to explore the cultural practices of South Indian grandmothers on breastfeeding pattern. So for this study, formulated only 2 objectives. What are the views or ideas of grandmothers related to breastfeeding practice? And what are the cultural practices that strongly influence in promoting breastfeeding practices among the mothers? Methodology: the research approach is a qualitative research approach. The research design is the chronological design, setting the postnatal wards of one of the tertiary care hospital with 1,500 bed capacity in South India. The samples are all religious South Indian grandmothers in postnatal wards who are taking care of the mothers in the postnatal wards. The sample size comprises of 10 South Indian grandmothers, and data collection were done with the audio taped interview with the unstructured questionnaires. The data analysis done by using the modified Colas's 5-step methodological interpretation, and the tool we have used only the interview schedule, unstructured questionnaire, and also the demographic data collected from the participants. So the age group of the participants, majority of them were in the age group of 51 to 55 years, and majority of them were the Hindu religion, and the educational status, yes. So majority of them had only the higher secondary education level, and only one where they graduate. The income was measured in rupees. That is, majority of them, that is, fall in the category of 4,001 to 5,000 rupees for their income. Majority of them, they had the pension scheme. So they revealed that they are getting the pension from the government like that. And the type of family, majority of them from the joint family system. So the findings and conclusions of this study were analyzed and placed under the different themes: knowledge and belief about the breastfeeding, support for the new mothers, health belief, management of the breastfeeding, practices of water and the breastfeeding, and practices of the artificial feeding. So let me start with the one by one, the themes. The knowledge and belief about the breastfeeding. So majority of the grandmothers were expressed that they used to destroy the colostrum. So they think that the colostrum is the contaminated milk. So it is not suitable for the baby, the newborn stomach. And they used to supplement their colostrum and early milk with the boiled water, or some of them they use that they will give first a honey for the better digestion. So they think that if they give colostrum first, then it will interfere with the digestion. So what are the cultural practices they have? First, they used to give the honey. Majority of them agreed they used to give honey or the sugar water in the beginning. So they thought that it will set right the GI system to follow with the other, maybe the colostrum, or maybe followed by the breastfeeding milk. So grandmothers used to soften the breast with the warm water and hand express the colostrum off. So they will just discard the colostrum, and they don't prefer to give this colostrum to the newborn babies. So if you verbatim have given here, the milk was boiled and has been stored in the breast for a longer time. So they think that this is a dirty milk. So colostrum is very thick fluid, and it will be difficult for the babies to digest. So they thought that it's a very, difficult component, and they cannot be digested by the newborn stomach. So some mothers, grandmothers, they gave the statement like, God gives milk to the breast as a gift for the baby. So you will have to answer to the God if you have refused to give your milk to your baby. So this statement, only few people, they got a clear understanding that the breast milk should not be wasted, and it should be given to the baby. But majority of them, they told that it is a dirty milk and this is not good for the newborn babies. So some mothers, they told that mothers should feed for at least 2 to 2.5 years, and the mother's milk stays in the child body for 40 years. They think that it is very good if the newborn is fed with the breast milk in the early years, and it will be helpful for the newborn in the future. Once the baby is grown up, and it will be give strength for the baby. So giving breast milk is very, very important. So these comments were given by only few grandmas. So breastfeeding makes a mother and her baby very close. So few grandmothers, they told that, yes, so breastfeeding, by giving breastfeeding, it creates a good relationship, the bonding between the mother and the baby. So they form a special bond, and when the baby grows up, and he or she will have a stronger feeling for her mother and be closer to her. So few grandmothers were expressed that mother's milk has all the nutrition which is necessary for baby's growth, where the artificial milk is not having all this nutrition. The second theme was support for the new mothers. So all grandmothers felt that they are very supportive for the mothers, especially for the new mothers. So they think that because the new mothers, they don't know anything about the care, even the overall postnatal care, in particularly on the breastfeeding. So they expressed that yes, they need elders, they need some like grandmas, like to give the overall support for the women to overcome, to pass through the postpartum period. So grandmothers also having a strong feeling that they are processing a rich source of knowledge and experiences, so that they can help to the problems and give advices about the baby care, including the feeding. So mothers should not be worried about anything and should take enough rest. So we can take over the many of the household activities even after the discharge from the postnatal ward, and so that the baby will get enough milk. So some grandmothers, they thought that if the mother is taking adequate food and adequate rest, it will directly helpful for the mother to have the adequate milk supply, and it promotes the breastfeeding. So mothers should not be, okay, sorry, this is one repeated. 17, 18. So breastfed babies have better brains, were clever, and had stronger bones. So if they had very good thought or the opinion about the breastfeeding. So baby fed with this breastfeeding, they will have the better brains, better IQ. They'll be very knowledgeable in the future, and they'll be very clever, and also have the influence on for the stronger bone development. And also, half of the samples knew that the benefits of the breastfeeding to the mother includes less risk of breast cancer, more weight loss, and delaying menstruation, so preventing pregnancy. The fourth component is the management of the breastfeeding. So majority of the grandmothers verbalized that they used to give advice about how to position the baby at the breast, trying different positions. So they have their own different positions. Actually, they by virtue of the practice, and they try the different positions to give the feeding, but they strongly object the side lying position. So the grandmothers, they told that sideline position is not good for the baby. Sometimes mother may lie on the baby. Sometimes it will suffocate the baby. Sometimes while in the sideline position, sometimes even it may cause the suffocation, even the feeding complications for the baby. Sometimes baby may vomit, or it may go for the aspiration. So they have the knowledge about this one position, but they're trying different positions, even though they're objecting the sideline position. Sometimes they teach how to hand express the milk to relieve the engorgement or heal the nipple sore. So grandmothers will make sure that the mothers are eating and drinking well with plenty of water, fresh juice, milk or tea or the coffee. They think that the milk, the tea and the coffee have the significant influence on the breast milk secretions. So majority of the grandmother, they expressed that they advise, they prefer to give the coffee and the tea during the postpartum period. So they thought it will influence, it increases the breast milk supply in women, in the postnatal mothers. And so they don't prefer not trying to go on a diet. So they don't, none of them had the opinion about having the balanced diet will increase the breast milk supply. So they thought that only the coffee, the tea, or they expressed that the Horlicks, they have the brand called Mother's Horlicks. This Horlicks also will have the significant influence on the breast milk supply. So if there is not milk or not getting adequate milk supply, grandmothers used to advise to take large the quantity of garlics. So they mostly rely on this garlics intake. So they have the strong belief garlics have a direct influence on the breast milk production. Or the mother's Horlicks. This is a very known brand which is locally available for these postnatal mothers. So they have the strong belief on this mother's Horlicks will definitely improve the milk supply or the large quantity of the milk. If the postnatal mothers, they take large amount of milk and it will directly influences the milk supply in the breast, or water to increase the milk secretion. So they have this kind of myths, beliefs, and the practices towards in the initial period of establishing the breastfeeding pattern. So presence of any breast engorgement will be relieved by expression of the breast milk from the alveoli. Thereby, they will relieve the problems of the engorged breast. So they have, everybody, all the grandmas, they have the awareness about how to relieve the breast engorgement by the milk out of the mammary gland, so that the engorgement will be minimized. Any nipple sore will be managed by applying the mother's own breast milk over the nipple, or the application of coconut oil over the nipple sore. So they have this strong belief that only the breast milk, majority of them agreed, if the mother apply the breast milk over the nipple, and automatically it will heal the nipple sore. And some of them, very few them agreed on the effect of the coconut oil on healing the nipple sore. But they don't believe on this applying the Vaseline or other the skin creams. They are not for that. They are objecting the use of the other substances other than the mother's own breast milk and the coconut oil. If mother is getting over milk supply, so that we managed by expressing out the secreted milk from the breast and keeping soft cotton cloth over the breast. So if the mother has the excessive milk supply, so sometimes they used to express it out manually, and sometimes if even to maintain to prevent the appearance, they used to keep the padded up soft cotton cloths inside the blouse, so that it will be absorbed by the cotton material, so that it will not be visibly out. So a few grandmothers were expressed that mothers should not take adequate feeds, especially to decrease the quantity of oral fluids. So they have the wrong myth here that if the mother has the excessive milk supply, so immediately they will reduce the intake of oral fluids, all kind of the liquids. So they have believed that if the mother is taking excessive amount of liquids, the oral fluids, and definitely it will increase the breast milk supply. So once the mother has experience of the over milk supply, and immediately they will reduce the intake of oral fluids in terms of coffee, the milk, the tea, whatever the fruit juices, etc. So few were explained that increase the interval of feeding, they were reducing the stagnation of milk in the mammary gland, and also they don't believe on the scheduled feeding. So they strongly believe that whenever the baby cries, okay, take the baby and feed the baby, so that the milk will not be stagnated in the mammary gland for a longer time. And so even to reduce the milk supply, also to avoid the over milk supply, also the interval should be increased. So they have this good and the positive knowledge towards how to manage the over milk supply. The fifth theme, the practices of water and the breastfeeding. So all the grandmothers felt that babies should be given small amount of boiled water from a few days old to a few weeks old, because they thought babies get thirsty and need a drink, and their skin is better and less dry if they have the water. So this is 100% of all the grandmothers, they agreed that baby need extra fluid. So baby should be fed with even the warm water, okay, and sometimes even the additional milk, extra milk other than the breastfeeding. So it is necessary, it is must for the babies to keep the baby skin better, and even they think that if we are not giving the fluid to the baby, and baby used to get thirsty. So they agreed believe that baby needs extra water other than the breastfeeding in a routine practice. So others suggested that mixing a little sugar with the water to give to babies who do not feed well and get tired. If the baby has any indigestion, or baby is not taking the feed well from the mother, or baby is always sleepy like that, so they used to give the sugar with the water. So they will mix the warm water with the sugar, and they used to give it in a feeding bottle, so that they thought that it will set right the GA system. So the baby will have a clear GA system. So next time, maybe after a few hours, baby will start to take a good feed like that. So they have this strong belief, giving the sugar water the baby is not taking adequate feed from the mother. The last theme, the practices of the artificial feeding. So few grandmothers felt as artificial milk powder is easily available and mothers can stop breastfeeding even by 3 months or before. So most of the grandmothers, they agreed that if the postnatal woman is going for a job, or if she's an employed woman, so they are giving the advice that, okay, up to 3 months or even before, she can give the milk, and after that she can stop it. Once she is out of the house, once she is going for a job, and very well the artificial milk is very well available and we can give, nothing wrong in that, nothing wrong. So they have a belief that the breastfeeding or the breast milk will be replaced by the artificial milk, which is readily available in the market. So grandmothers felt that young mothers are verbalizing as, that was your time, this is our time. So they used to compare the generation. So when you were there, when you were as a mother, young mother, you were practicing this. That was an old pattern. Concept, old practices. This is our time. We have our own the practices to carry on like that. So grandmothers revealed that the feeding mothers experiencing us do not teach all the old stories to us. Moreover, we know better than you because we are in a recent century. So early we start the weaning, better the health for the newborn. So majority of the grandmothers expressed that the feeding mothers giving a statement as, we are in 21st century, so we know the nutrition sources and food sources better than you. So we have our own decision to continue the feeding. So some grandmothers revealed formula milk is very good for the faster growth and weight gain compared to the breastfeeding. So most of the grandmothers, they are voting for the artificial feedings. Yes. So yeah. To conclude this topic, so grandmothers are the central figure in the breastfeeding support for the daughters or even the daughter-in-laws in the breastfeeding, or discourage the breastfeeding with the contrary opinions and inadequate guidance. And there are many cultural myths, the beliefs, the practices are prevailing in their own cultural system. So breast care and breastfeeding is in need of the hour. It calls for healthcare professionals' attention. Lot of wrong belief, myth, and lack of education is prevailing among the grandmothers. They need proper education and timely preparation during the postpartum period regarding the breastfeeding. To recommend, the study can be conducted in a as even other quantitative method also. Health education. So here the very important vital role of the healthcare professional focusing on the health education. So this health education can be started in the postnatal ward of all the healthcare institutions, and booklet or the pamphlets or any kind of the educational material can be issued for the grandmothers, and regarding the breastfeeding during the postpartum period, and what are the complications, how to manage the breastfeeding, with all the resources. And thank you so much for your attention, the time, and for the organizers giving me this opportunity. Thank you so much.
Yes. So this was the presentation from Dr. Gayatri Priya. Any questions regarding this topic? If you have any questions regarding this topic, you can text in chat box. We will be asking behalf of you, even after the completion of the Congress. Yes. Thank you so much, madam, for joining this event, and hope we expect your presence for next year in face-to-face meeting that is going to happen in, yes, that is going to happen in Valencia, Spain in the month of
Okay,
June.
thank you, sir. Thank you so much for the opportunity. Thank you. Yes. Sure. We will see you next year.
Yes, you'll be getting the participant certificate within a couple of days, along with book proceeding as well as certificate parcel.
Yes.
Thank you so much.
Yeah. Thank you, sir. Thank you so much. I will just stop sharing. How to stop further sharing? I don't know. Yes. I hope I stopped the sharing.
Yes. So next we ask. Yes, sir. Next we ask Dr. Kim Yakov to start. Yes. So as soon as you complete your talk, just you can mention the word slide change. I'll be changing from here, sir.
Okay.
Yes, you can start your presenting.
Yes. I am Yakov from Kerala, India. Today I want to discuss with you the subject is Can you hear me?
Sir, it's fine.
Okay. The definition, diagnosis, and treatment of fever are against modern science in the world today. Why? Next slide. The definition, diagnosis, in both science and medicine, unseen irrationalities are used in fever, definition, diagnosis, and treatment. Next slide. Introduction. There is no uniform definition, test, or treatment for fever alone. Today, the diagnosis and treatment of fever are similar to the diagnosis and treatment is opposite, destructive hypothermia. The essence of today's fever treatment is fever can be cured by using fever-creating substances. Next slide. Medical textbooks state that our understanding of the neural basis of thermoregulation fever is still rudimentary. The role of fever in the defense reaction is not clear. Fever and hypothermia, they are not yet universally defined, and there is no agreed definition of fever. Next slide. Researchers found that even a single dose of paracetamol can reduce the body's level of glutathione. It will increase inflammation. So, paracetamol may cause fever, neutropenia, thrombocytopenia. Paracetamol, a familiar drug with unexplained mechanism of action. The use of antibiotics might prolong infection, and that in severe infection, the use of antibiotics might increase mortality. Next slide. The current diagnosis and treatment of fever are based on the belief that the fever temperature between 100 degrees Fahrenheit to 107 degrees Fahrenheit is harmful to brain and body. Next slide. The current definition of fever is against modern science. First point. The definition of fever should include things that occur only during fever. This is not in the current definition of fever. The current definition of fever is usually only elevated body temperature above 100 degrees Fahrenheit or 38 degrees centigrade. Next slide. In many medical books, we can see different types of fever definitions. It is against modern science to give different definitions for one thing, that is fever. Next slide. An elevated core body temperature of more than 38 degrees Celsius is not a scientific definition. Elevating the temperature is an action like walking and sitting. The definition of fever does not even say why the temperature is elevated. Next slide. The criterion for definition is not found in current definition of fever. The definition of fever does not even say why the temperature is elevated because it is not known what the temperature of fever is. Modern science has not investigated what our immune system does with the heat energy of fever. Next slide. Current knowledge about fever is based on speculation. The concept of thermoregulatory ligand, where the hypothalamus elevates the temperature at the thermoregulatory ligand, is a speculative idea. There is no objective evidence for this. In some diseases, only certain parts of the body have an increase in temperature. Next slide. The seriousness and danger of the definition of fever is recognized when the diagnosis and treatment of fever is not based on current definition of fever. Next slide. Today, hypothermia is called fever. As you are aware today, hypothermia is divided into three categories. Mild or low grade hypothermia, moderate grade hypothermia, and high grade hypothermia. Fever is also divided into three categories based on the severity of the body temperature. Mildly low grade fever and moderate grade fever, the high grade fever and hypothermia. The same temperature is used to determine fever and hypothermia. According to any science, next slide. According to any scientific law in the world today, the same temperature should not be called fever and hypothermia. The basic reason why hyperthermia is called fever is that there is no definition that differentiates between fever and hypothermia. Next slide. A condition in which the body temperature exceeds 100 degrees Fahrenheit is called hyperthermia. It is not a fever. Hypothermia can be divided into two: destructive hypothermia and protective hypothermia. Next slide. One is destructive hypothermia. Destructive hypothermia is a temperature that the body feels uncomfortable and haze due to excessive and uncontrolled temperature generated from the outside the body. In this, the body gets overheated due to external factors like fire, sunlight, acid, various drugs and processes. Next slide. Protective hyperthermia. Protective hyperthermia is when immune system partially or completely controls body temperature below the comfortable and preferred temperature of 107.6 degree Fahrenheit to increase blood flow while inflammation decrease blood flow. Next slide. The immune system produces protective hyperthermia not only in fever but also in many diseases that reduce blood flow due to inflammation. In fever, the immune system produces only protective hyperthermia, not destructive hyperthermia. Next slide. Protective hyperthermia does not cause any disease or discomfort. In this, the body likes to increase what the body needs and decrease what the body does not need. In protective hypothermia, the immune system does its best to raise the temperature. The body likes to raise its temperature. There are certain substances that are increased and decreased by immune system only during protective hypothermia, that do not increase or decrease during destructive hypothermia. Next slide. Fever cannot be created by heat-inducing substances. Fever can be created by heat-reducing materials. In Tamil Nadu, the practice of Talekutal. In Tamil Nadu, the state of India, the practice of Talekutal is the practice of killing a person by creating fever with cold water. There is basically no difference between the different types of heat. There is a difference in who made this heat, for what purpose, and how. Next slide. When the immune system raises the temperature to save the body or organ, it prepares other favorable mechanisms and conditions. In this, the body likes the rise in temperature. Those who do not know what is the life-saving protective hypothermia think that it is destructive hypothermia. As a result, morbidity and mortality increase. Next slide. Point 2, the current diagnosis of fever is against modern science. There is no test for fever alone. The current fever test is not a proper fever test. The current method of diagnosing fever is when the body temperature rises above 38 degrees Celsius without logic. Next slide. There are things and activities that only happen when you have a fever. For example, increased production of pyrogens, TNF-alpha, cold-sensitive neurons, etc. These should be checked to determine the fever. Body temperature rises not only during fever, destructive hypothermia and opposite of fever also occurs in uncomfortable temperature. Also in many diseases where blood flow is reduced due to inflammation, the temperature will rise partially in many parts of the country. Next slide. There are substances that increase and decrease in the body only during fever. Fever should be diagnosed by examining these substances. Such a diagnosis does not exist today. The current fever testing does not meet the definition of fever. As with the destructive hypothermia, fever is classified, diagnosed, and treated based on the increase in body temperature. Next slide. Today's fever tests are not based on fever definitions. An increase in temperature is not in fever by definition. Fever is elevated temperature in the hypothalamus. According to definition of fever, the temperature in the hypothalamus brain is not checked whether it is elevated in set. Instead, a fever is diagnosed when body temperature rises above 100 degrees Fahrenheit. Next slide. The thermal control line and temperature set point on this line cannot be verified and identified with existing equipment. It is said that at different temperatures levels, the healing mechanism begins and the cooling mechanism begins and is plotted on a piece of graph paper. This is also not done at a practical level to detect the patient's fever. Next slide. 2.2, a thermometer is a temperature measuring device, not a fever measuring device. For those who know the definition of fever, who know what are the things that occur only when there is fever. What is fever? The purpose of temperature of fever. What is the role of fever in defense reaction? How is the thermoregulation of fever? And who can distinguish between fever and destructive hypothermia, etc.? A thermometer is a temperature measuring device, not a fever measuring device. Next slide. For those who are unfamiliar with the above fever basics, a thermometer is a fever measuring device, not a temperature measuring device. Next slide. Diagnosis and treatment of destructive hypothermia is now performed for fever involving protective hypothermia. This is against modern science. There is no system or tool that differentiate between destructive hypothermia and protective hypothermia based on the nature of hypothermia seen as heat. Without a protective hypothermia measuring device or system, even a fraction of fever cannot be detected. Next slide. When physicians say that many diseases are caused by fever and it is a symptom of many diseases, today's fever tests cannot detect whether a fever is the cause of disease, whether a fever is causing pneumonia, or whether a fever is a symptom of disease. No one can objectively prove this by any existing scientific law, experiment, instrument, or scientific technique. Next slide. Applying the same test to conflicting objects and multiple definitions is against modern science. Today's fever tests do not even have a fraction of the different fever definitions. Next slide. Today, fever is diagnosed by looking at temperature above 38 degrees centigrade. The same temperature is used to determine destructive hypothermia. Destructive hypothermia, which is opposite of fever, cause an increase in high body temperature. The heat produced in hypothermia is not produced by immune system as in fever. Next slide. Who created the temperature between 38 degree and 42 degrees centigrade and for what purpose is very important. The same test is wrong for fevers that are spontaneously generated by the immune system with a clear goal, and for destructive hypothermia that is not caused by anyone without a specific goal. Next slide. The criteria for measuring temperature for fever and destructive hypothermia are unscientific. Temperature rise is a signal of a fever and destructive hypothermia, which are caused by contradictory substances and can be eliminated by contradictory substances. Regardless of above contradictions, it is unscientific to assume that temperature above 38 degrees centigrade are criteria for determining the difference between fever and destructive hypothermia. Next slide. A fever diagnosis that does not include the activity of the immune system, which occurs only when a fever is present, is ineffective. Treating mutually exclusive fever and destructive hypothermia with the same test is a murderous attempts. Next slide. Patients with a fever and low temperature hypothermia are more likely to be assessed as destructive hypothermia when they lie unconscious in the sun and are rewarmed externally. The unconscious patient lying in the sun is brought to the nearest hospital. If only temperature is checked, hypothermia or fever cannot be identified. The basic elements necessary for a scientific diagnosis are not provided in fever diagnosis. Next slide. There is no need to look at the body temperature to detect fever. No system or device exists to distinguish between destructive hypothermia and protective hypothermia. Without a protective hypothermia measuring device or system, even a fraction of fever cannot be detected. Next slide. The most important in fever examination should be the substance produced in body only during fever, their functions, signs, symptoms, signals, and messages. If anyone is the opinion that none of these should be tested according to modern science, please state according to which science. Next slide. Third point, the current fever treatment is against modern science. Current fever treatment is not a proper fever treatment. All Vedic tests describe fever as a fatal disease. Current fever treatment are based on the Vedic tests. Modern science has not yet been able to change that. Next slide. Proper treatment of fever is to restore all things that, proper treatment of fever is restore all things and activities to their former state, which only occurs when there is a fever. This is not in the current treatment of fever. Next slide. Without knowing what the fever heat is for and what activities our body has done with this heat energy, fever treatment is done today to reduce the temperature. Next slide. Today, fever treatment does not meet the current definition of fever. Today, the treatment of fever are similar to the treatment of its opposite, destructive hypothermia. Next slide. A patient with a fever like this is taken to the physician if fever temperature is above 106 Fahrenheit. Regardless of the cause, the doctor implements the recommendation in the medical books to reduce the temperature immediately by immersing in ice water, regardless of the purpose of fever. Every time the immune system is treated to reduce the temperature, the immune system works against it, shivering, shrinking the skin, and responding to the reflex action of the reflex action to increase the temperature. Next slide. The energy to shiver and heat is diminishing. Thermal energy continues to produce heat until the body's energy is depleted. Energy is not available to generate even normal body temperature of 98.6 degree Fahrenheit. That is normal body temperature. Sorry. The body then reaches a dangerous state called hypothermia, where the temperature drops below 35 degrees centigrade. This leads to decreased thermal energy and increased disease and death. Next point. Next slide. A physician trying to reduce the temperature of fever thinks that he has helped to save the patient from death, but he did not know that the temperature of fever was to increase the flow of blood, but he turned into death-dealing executioner. Next slide. No question about a fever can be answered if questions are asked assuming that the current definition, testing, and treatment of fever are correct. No one can provide any objective evidence that the current definition, diagnosis, and treatment of fever belongs to modern science. Next slide. According to any existing science in the world today, fever and destructive hypothermia should not be diagnosed and treated in the same way. Doing so is against modern science. Evidence from modern science is used here to demonstrate that the current definition, testing, and treatment of fever is against modern science. Next slide. If there are those who hold that the above is not the correct standard to prove that the existing definition, examination, and treatment of fever are wrong, if a new standard is proposed, I am ready to prove that the existing definition, examination, treatment of fever are wrong according to modern science. Next slide. It is against modern science to base the diagnosis and treatment of fever without a uniform definition of fever, without knowing what a fever is for, without knowing the role of your immune function, and without examining what functions the immune system uses in fever temperature. Next slide. If what we say about a subject is incomplete or unscientific, there will be many questions about it, and somewhere there will be a gap as if it is not met. But since anyone can recreate a fever with cold items, water, and paracetamol, none of the claims made against modern science and about current fever definition, testing, and treatment feel incomplete or flawed. Next slide. I have been able to impeccably prove the modern science that the current definition, diagnosis, and treatment of fever is against logic, science, and energy, and is destroying the man instead of saving him. Also, I discovered a new definition, diagnosis, and treatment of fever. I have presented in many scientific forums and published in various medical journals. Anyone can reduce fever in 20 minutes according to new method I discovered. Next slide. This is a discovery that leaves no room for doubts about fever. Therefore, this finding will not be corrected even in the future. To save lives, it is imperative that a new definition, diagnosis, and treatment of fever be implemented worldwide immediately. Next slide. Conclusion. Conservative fever definition, diagnosis, and treatment are against modern science. It has no relation with what is happened in fever. The base elements necessary for a scientific definition, diagnosis, and treatment are not provided in conservative fever definition, diagnosis, and treatment. There is not a shred of definition, there is not a shred of evidence to show that the current fever definition, diagnosis, and treatment is belong to modern science. It should be revised according to what is happening in fever. A new fever definition, diagnosis, and treatment has been created according to modern science without any room for doubts or complaints. Reference. Thank you. Hearing me patiently so far.
This was the presentation from Dr. K.M. Jacob. Any questions regarding this topic?
I want to share this. This paper is published in a journal. I want to share the link of the paper.
Yes,
So
sure,
please
sir.
please check the chat box after 1 or 2 minutes.
Yes. Any questions related to this topic? Just you can text in chat box. We'll be asking behalf of even after the completion of the Congress. Yes, thank you so much, sir, for joining this event. And you will be getting the participation certificate and booklet within a couple of days. Thank you so much once again.
Okay, please check the chat box.
Yes, got it. Thank you so much, sir. Next, we'll go with alternate speaker, that is Dr. Asta Mongole from Mongolo Public Health Expert, International Independent Council from Cameroon. The topic will be role of the nurse in achieving universal health covering in sub-Saharan Africa. Yes, madam. You can, if you are ready, you can start sharing your slide.
Up the slides. I shared the slide with you. Let me check and I shared it. Give me 1 minute, please.
Okay, no problem.
Do we have my screen?
Yes.
Okay. Thank you very much. My name is Asta Monglo. I am a public health expert working now as an independent monitor, consultant for organizations such as the WHO. I am currently working for Bill and Melinda Gates Foundation via Mackin Corporation. I am appointed in Africa Regional of the WHO Regional Office for Africa. I'm mainly working with polio program. So let me talk about the role of the nurse in achieving universal health coverage in sub-Saharan African countries. So you know now, all health policy in many countries in Africa are moving towards universal health coverage. Africa has an annual population growth is the highest in the world because it stands at 2.7 compared to 1.1 globally. This was in 2020. And the population of World Health Organization, for example, represents 14.4% of the world population and of the world population. And although the density remains low, I'm sorry for the background noise. It is raining here. Although the population density remains relatively low, we have 36 inhabitants per kilometers. And why are we talking about density? Because it is an essential parameter for the health policy and governance to implementation, and because it determines access to different services. So, but sub-Saharan Africa also faces a series of health challenges impacting population health. And universal health coverage, which is a measure global in health, appears to be a solution and represent a guarantee that all people have access to quality health care regardless of their socioeconomic status. And also to move toward this goal, WHO recommend to reorient health system with primary healthcare, and you know that universal health coverage activities are mainly delivered through primary healthcare. So what is the specific role that can nurse play in achieving universal, in implementing universal health coverage in sub-Saharan country? What are the key challenges they need to overcome in making the unique contribution to UHC? The objective is this presentation to answer this question and also to open the necessary path of perspective for the better implementation of UHC in Africa in general and sub-Saharan country in particular. So the contents are, we will bring out major health challenges in Africa, and then we'll talk about universal health coverage and the related challenges. And we bring out the crucial role of nurses in achieving this and the related challenge in Africa context, and we open the path for nurses future to achieve UHC in sub-Saharan. And before conclusion, and if you have any question, you can try to answer. So, major health challenges in Africa. We have, for example, limited access to basic health care. Many people in Africa does not have access to basic health care due to the distance from the resident to the health of to health facility, or lack of inadequate maternal infrastructure, medical infrastructure, financial difficulties to pay for care, and at least half of the population health does not have access to essential health care. That is stated by WHO in 2017. We have also high prevalence of communicable diseases such as HIV/AIDS, such as malaria, and also tuberculosis. We have shortage of skilled health personnel, and the region is really severely affected with shortage of healthcare professionals, resulting in an unfavorable health to patient ratio. We have underfunding health systems, and despite the Abuja Declaration made in 2001 called for 50% of the national budget to be allocated to health, until now, just few countries have achieved this goal. We have also health inequalities such as access to care, HIV, economic, education, and gender inequality. We have also maternal and child health challenges, because the region is experiencing the high mortality and infant mortality rate due to limited access to antenatal care, assisted delivery, and health care for children. We have outbreak and crisis, and the example of outbreak, Ebola, and recently the COVID outbreak shows that we have many challenges in our health system. And we have also other health challenges such as antimicrobial resistance, inadequate supply of medicine and medical equipment, nutrition challenges, and also immunization challenges, and etc. So what is universal health coverage about? What are the related challenges? The World Health Organization defines UHC as equitable and universal access to quality health services without healthcare costs leading to financial hardship for individuals and family. For the World Bank, universal health coverage means that all people have access to the health service they need when and where they need them without experiencing financial hardship. And for the African Union, which universal health coverage is also a major goal to improve the health in Africa, it aims to ensure universal access to quality health services at an affordable cost. You see that this definition emphasizes the importance of ensuring access to quality health care for all without healthcare costs being a financial barrier. So, and the framework, the conceptual framework illustrating universal health coverage place for the good health and well-being, which is a sustainable development goal number three, requires achievement of health-related sustainable goals. Also, universal whole, improving target for universal health coverage, and also improving target for health security. And for this to occur, the country needs to invest in health systems as input. And investing in a health system so that they can build a strong health system, it is essential to consider not only environmental context, but social context, economic context, political context. And for this purpose, the central and key or basic components are health workforce, health products, and health infrastructure. So in summary, we need continues to make this input, building this to create effective demand, better access, high quality, robust, resilient, so that they can also improve health-related sustainable goals to be achieved targets, and also to improve universal health coverage, health security, and the impact will be attainment of good health and well-being with maximal health impact, attaining an equitable and efficient and effective manner. That is what we can say as the framework illustrating universal health coverage in good health and well-being. What are the related challenges? The major challenges and obstacles in terms of UHC mesh with the challenges in health and as developed in the previous slide. We have access to healthcare is limited by inequality. We already talk about economic, geographical, gender, education, immunization. All these inequality are limiting access to healthcare. We have healthcare resources inequalities and the lack of financing. Health infrastructure, medical resources, and health workforce are often unfairly distributed across Africa. Insufficient financing of healthcare, we already talk about it. We have governance issues, such as corruption, poor leadership, and mismanagement. This can hinder the effective implementation of universal health coverage. In addition, cultural and social barriers should be considered for better implementation of health, universal health coverage, because cultural beliefs, social stigma, and community norms can influence access to healthcare. In summary, achieving universal health coverage in Africa and in sub-Saharan countries is complex due to various economic, political, social, cultural, and logistic barriers. So, what is then the crucial role of a nurse to achieve universal health coverage? The nurse play a vital role in health system in general, which can be summarized as follows. They can play a role in management of health communicable or non-communicable diseases. Their role in primary health care, I recall here that the universal health coverage is mainly based on in primary health care approach. They can be advocate for policy changes and also increase resources. They can play a role in leadership, governance and advocacy, evaluation and research, education, interprofessional collaboration, coordination of, and they can also take part in decision making. They can raise awareness for health education and promotion, and they can be also creative and innovative. But we have also some challenges and barriers for them to really play their role. The first one of the challenges is the shortage of skilled nurses, lack of adequate training, migration of health workers. I think Dr. Abdul have talked about it earlier, why she talked about brain drain of health workers. So another part of the world, and aging nursing workforce. We have training skills. Education programs are not tailored to local needs and the specific health challenges in the of the region. In most nursing schools, the syllabus seems to not be adequate or well adapted to the population health needs. Working condition and remuneration, poor working condition, low wages, and lack of intensive. Access to resources and equipment. Health facility in Africa may lack of basic medical equipment, medicine, and supplies. And access to information and technology. Access to medical information and health technology is essential for nurses to make wise decisions and improve her quality. Now, what are the paths for nurses featured to achieve USC in sub-Saharan Africa? To strengthen the role of achieving universal equity, the main strategy to be adopted are strengthening the nursing training and education. Countries need to invest in continuing education for nurses, especially in rural areas, to ensure they have the skill they need to provide quality care. Promoting interprofessional collaboration, encourage collaboration between nurses, physicians, pharmacists, and other health professionals for more effective care delivery. Supporting public health awareness. Nurses can play a major role in raising awareness of disease prevention practice, including immunization, hygiene, and nutrition. Improving resource management. Nurses can contribute to the effective management of medication and medical equipment, helping to reduce health care costs. Improving access to healthcare in rural areas. A study in Ethiopia conducted in Ethiopia found that many rural areas have limited access to healthcare services due to the remoteness of health facilities. So they train mobile nurses and to complete that gap. Management of epidemic and healthcare, the Ebola outbreak, as I told, and in West Africa, and more recently, they have underlined the need of effective mechanism of managing public health with the involvement with nurse-specific role, and controlling the prevalence of communicable diseases is one also of the activity that nurses can have something to do. In conclusion, the presentation aims to examine the crucial role of nursing in implementing universal health coverage in sub-Saharan Africa, while highlighting the complex challenges they face. Nurses, as frontline healthcare providers, are often the first agent of contact for many communities in Africa. They are well positioned to provide prevention, health promotion, and treatment services, making them the player in expanding access to healthcare. However, there are significant obstacles to their effectiveness. This includes the shortage of skilled health professionals, lack of inadequate infrastructure, geographical and socioeconomic inequality in access to care, as well as cultural barriers. These barriers require multifactorial solutions, including investments in training and capacity building for nurses, the expansion for basic health services in rural and disadvantaged areas, and the development of more inclusive health policies. For nurses to play the full role in achieving UHC in sub-Saharan Africa, it is necessary to recognize their contribution, actively involved in health policy planning and implementation, and promote interpersonal collaboration within healthcare teams. In addition, better pay and working conditions are key to attracting and retaining qualified health. So that is what I was having. We have references, some references here. And also, thank you for your kind attention. And if you have any question, I will try to answer. Thank you very much.
Yes. Any questions? Any questions to Dr. Monglo? Just if you have any questions regarding this topic, you can text us, or you can mail us even after the completion of the Congress. Yes, thank you so much, madam. You'll be getting the participant certificate as well as booklet within a couple of days. Thank you once again. Hope we expect your presence for next year in face-to-face meeting.
Thank you.
Yeah, thank you so much. Thank you for your patience. Have a nice day.
Thank you. Thank you very much.
Yes. Next, we ask Dr. Amal Khalil from King Saud bin Abdul Aziz University for Health Sciences College of Nursing from Kingdom of Saudi Arabia to start presenting.
Hello, everyone.
Yes, ma'am.
Yeah, did you listen me and you see my screen?
Yes, it's fine.
Yes, thank you so much for inviting for this important conference. Okay, and it's my pleasure to be with you. And today I'm going to present impact of training prevention program in bullying and prejudice among adolescents toward ending bullying behavior. It's a randomized experimental study. And look at for this significance of bullying. What do the following people have in common? If we look, all these, they are famous people like Woody Allen, Ronald Dye, Walt Disney, Mel Gibson, Cliff James, and all of them. Okay, if we look for them, okay, we'll find that they've been bullied in school. And according to the worldwide statistics, okay, 1 in 5 children is bullied in a regular basis. If we look for the prevalence in the settings that we collect the data, 27% of children between year 4 and 7 reports being bullied regularly, 1 in 4. And the peak is at year 5, it reached for 32%. In most cases, it's 87%. Other children are witnesses to what is happening. And 1 in 7 children have a regular experience with bullying, consistent rate between 10 and 15% of all children being subject to bullying at least once a week. This is why we conduct our study, okay, believing that every child has the right to feel safe, okay, receiving his education in a safe environment, free from any pervasive traits of bullying and prejudice, the prevalence and determinantal impact of bullying among children and adolescents necessitate serious attention and comprehensive action. To combat these pervasive issues effectively, it is imperative to develop interventions that address the diverse form of bullying, including physical, verbal, social, and cyberbullying. Additionally, this intervention should be firmly grounded in established theoretical framework to provide a clear understanding of their underlying mechanism and unique contribution to the field. Despite the significant progress in research and intervention effort, a critical examination of existing literature reveals that still there is a need for interventions that go beyond conventional approach. This study aimed to contribute to the existing body of knowledge by presenting a novel bullying and prejudice intervention that offer a distinctive theoretical rationale and differentiation from previously published intervention. At the core of our intervention, it lies a robust theoretical foundation based on prominent theories related to bullying and prejudice, drawing from the social learning theory, social cognitive theory, and social ecological model. Our intervention seeks to address bullying as a complex interplay of individual, social, and environmental factors. By incorporating this theory, we aim to develop targeted strategies that not only address the immediate bullying behavior, but also consider the broader social context that perpetuates and sustains such action. Embarking on this pioneering study, our motivation is rooted in the belief that our innovative intervention targeting bullying and prejudice will offer a valuable addition to the field. And by grounding our strategy in well-established theory, differentiating our approach from existing intervention, and addressing the specific need of a diverse population, we are confident that our research will help in advancing the collective effort to create safe and inclusive environment for all children and adolescents. Therefore, our study looked at an exploration of participant perception toward both behavior involved in assessing their feeling about bullying, as well as their concern about prejudice. Additionally, the study aimed to identify the participants' subjective emotion concerning this behavior. So the primary objective of this present study was to examine the effect of a training prevention program in reducing incidents of bullying and prejudice among adolescents attending 103 schools in Jeddah, Saudi Arabia. The study seeks to answer the following research question: what is the effect of the prevention training program in the knowledge of adolescent students before and after the training intervention? And second question, what was the impact of the prevention training program in prejudice, prejudicial attitude and skills related to bullying behavior before and after the educational program training? As well, the question number 3, how did the demographic characteristic of the participant influence the effect of pre-post educational training about bullying behavior prevention? And we hypothesize that a training program does not impact the knowledge of the participant in pre-post educational training, and then the positive aspect of the program that it will affect the knowledge in pre and post educational training. And the other one, the program impact prejudicial attitude and skill among the participant in pre-post educational training. And the last one is the demographic characteristic of the participant impacts the pre-post educational training in the role of prevention behavior program. And the theoretical and conceptual framework based on this or guiding this study, several relevant theories, including this Pandora social learning series, suggests that individual learn through observation, imitation, and reinforcement. In the context of bullying prevention, this theory can explain how adolescents acquire knowledge, attitude, and behavior related to bullying and prejudice. Here's a training program of considered it is the independent variable designed to provide the positive model, promote empathy, and teach nonviolent conflict resolution strategy, aligning with principle of social learning theory. As the other theory supporting the Pandora is a cognitive process which shaping the behavior of the children or behavior of student. It poses that individual belief and self-efficacy and outcome, which considers the dependent variable influence their engagement which we call it independent variable like the program. Here, the program target cognitive process by enhancing student self-efficacy in standing up against bullying, challenging, and these prejudice belief, and fostering positive outcome expectation of pre-social behavior. Furthermore, the intergroup contact theory also is one of the theories that guide this study. This theory suggests the contact between different social groups can reduce prejudice and improve intergroup relation. And the training program can incorporate intergroup contact strategies such as promoting collaboration and cooperation among a diverse group of adolescents to foster empathy and challenging the stereotyped behavior. Additionally, another theory, ecological system theory. This theory recognizes that individual influenced by multiple levels of social environment. We call it a microsystem, including the family and the school, and mesosystem, interaction between microsystem, and the ecosystem, community and media, and macro system, cultural norm. Here, the training program can consider the influence of this ecological system as a mediating potential variables on bullying and prejudice, addressing the factors that family dynamic, school climate, community support, and cultural value. Finally, the positive youth developmental theory is another theory that help to guide this framework, which focusing on promoting aspect or positive asset and strengthen young people to foster their overall development. Here, the training program can adopt this positive youth development approach by enhancing resilience, promoting empathy, fostering positive relationship, and encouraging youth empowerment in addressing bullying and prejudice. So when you go for material and method, our setting is at a school, middle school, 103. It is located in Jeddah city, Saudi Arabia, okay? This school located at Sulaimaniya district. School has 9 classes, 3 classes per each grade level, divided by 6. We took from the school grade 7, 8, and 9. So if we have 7, so it's 7A, B, and C, and 8A, B, and C, 9A, B, and C, and the number of students is ranged from 19 to 22 per each class. And sampling technique here is a sample random technique has been used to assign an equal number of middle level education. So our sample here is purpose of sample from the detected school. Here is the figures that guide are all students. They are 180 to 189 recruited as experiment randomly to experimental and control group from grade 7, 8, and 9. Okay, so we took their consent, and we received the list of the student name from the principal of the school after her agreement regarding the participation of the children. And we, based on randomization, so experimental group reached for 90 and the control group 90 also, with random assignment, experimental group having 7A and C, 8C plus 9A and B, while control group having 4 classes like 7B plus 8A and D and 9C, sorry. And here, these 5 classes, implementation of the program done for this group, okay, and control group, there is no intervention, while the pre-test and post-test is done for both group to test their knowledge and the effect of the program in changing knowledge pre and post. Okay, here the research design is randomized experimental study design was used to answer the hypothesis related to the knowledge and attitude of adolescent and middle level of education to decrease the bullying and prejudice behavior among them. What I want to talk about this, at this school, there are, as you know, Saudi Arabia has a lot of foreigners. So in one school, you can find a lot of nationalities among those. So bullying and prejudice may be present because of these different nationalities. Okay, so we believe that this design will be appropriate for us to achieve the cause-effect and the cause-effect relationship, as a researcher are able to actively ensure that 2 groups of participants are face equivalent chance. Our tool of the study, we have 3 tools, okay, demographic characteristic, asking the children about their age, their nationality, and their academic level, okay, and also the informed consent, okay, and then the bullying amongst diverse population. This is scale in 7 Likert scales, okay, asking giving the sample of statement, okay, and the student has to rate their response in this Likert or 7 Likert scale. Basic empathy scale also is a scale to measure the ability of the attitude of the student regarding the bold children, okay, and how they feel after bullying, and what about if they are victim, okay, did they can do witnesses, do they can intervene, okay. This is why we try to reach for the main concept is held by those children at middle school. Then, if we talk about validity and reliability, we found that all tools were translated into Arabic. This is the mother tongue of students here in Saudi Arabia. And after that, we back translated to ensure the verification of English and Arabic version, translated version distributed to a jury of professional nursing educator to detect or this face and content validity of the questionnaire, and to test reliability about study of 10 to 15 students from all grade level, like 7, 8, and 9, were given the questionnaire to know the clarity, ambiguity, and we measured this Cronbach alpha, okay, which was reported by the end and reached for like 86.9, okay. And data collection procedure here, okay, training has been presented using PowerPoint handout. Researcher in this study serve as a facilitator for both piece training in order to control the experiment by following step. Initial assessment was completed in the fulfilled questionnaire, informed consent, IRB approval, created code reviewed by all or for all participants, and the experimental group instructed to bring their code with them to the training to ensure that their first and second assessment could be compiled for data analysis. As a compilation of the training, every researcher left his assigned class and went for other class. So another member do the or distribute the post-test assessment to prevent undue influence on the assessment process by the researcher. And regarding the ethical consideration, approval, an official approval was received from research unit in the College of Nursing Jeddah, also KIMARC and IRB Center, King Abdullah IRB Center. Then the approval letter was submitted to Ministry of Education for approval. After that, approval has been sent to principal of the school. Then she contacts the parent of the student, okay, and who agrees that their kids can share in the study. Then the study subject approach to explain the purpose and the procedure of the study. Here, autonomy and the confidentiality was assured, and for each student, okay, and we inform them that the voluntary participation is required, as well as they can withdraw from the study at any time without any penalty, okay, as well as they've been assured that their answer and data and documents, all of here will kept confidential within the document of National Guard, Health Affairs Record and Premises. And when we reach for the experimental group, what they did, okay, after receiving the list from the principal of the school, okay, we reach for like 90. We divide the student into 3 small subgroup, like each group like 30, okay. A training program run and for 1 day, 2 hours. The program presented on 1 day, 6 hours, divided into 4 sessions as follows. The first session provide an overview about the bullying behavior, concern, prejudice, explore participant feeling regarding both behavior. Second session, we define bullying, differentiate between prejudice and discrimination. We identify the impact of bullying on the behavior and how it affects the psychological health of each children and list different type of bullying behavior. The third session was covering the technique of witness model technique, okay, and the fourth one covering the participant feedback and the question, as well as summarizing and closing second half of the session, given the questionnaire to fill the post-educational intervention. While the control group, okay, only they receive the pre-test as well as the post-test, okay, without showing or without doing any intervention with them. And the data management, coded, analyzed by SPSS latest version, data presented using this frequency as well as percentage and interval ratio variables. Independent sample t-test was done to compare between pre and post, as well as we analyzed total knowledge, attitude, empathy, and their practice role score participant response between experimental and control group. And appropriate statistical test was used to find the association between participant demographic characteristic, while the significant level tested at B less than 0.05. Here's the results. Okay. If we go for the results, we'll find that this table showing the demographic characteristic of the experimental as well as the control group. Here, as you see like 2/3 of the study sample representing the Saudi nationalities, okay, compared with 64.8 in control group, 66.7 were in middle age experimental, compared with 56.3 is like a control. However, there was no significant difference between both experimental as well as control group. On the other hand, 69% of the experimental were in average income, compared with 85.5 with significant difference at B 0.04. In addition to significant also difference was detected in participant attending workshop inside the school at B significant also less than 0.05. Okay, so here again, while more than half of the studied group equally were attending workshop with no significant difference between both groups. If we go for this is a continuation for the first one, and it was mentioned already, is the significance in attending bullying activities inside the school. There is significant difference. Also, this mother education or parent education, also in income. Okay, there is significant difference, and further education also it represents no significant difference. Okay. So here is the distribution of the studied participant according to experience with bullying and prejudice. If we go for this table, we find that according to their experience with bullying and prejudice, we'll find like 68.2 of experimental group were exposed to bullying by their classmate, compared with 60.6 of the control group were exposed to bullying by 59.5 of their classmate, with no significant difference between them. A result of the study also showed significant difference in bullying witness, and also regarding participant involvement in bullying, no significant difference was reported between control group and experimental group. If we look for comparison between experimental and control regarding their ability to perceive their role as pre-post, we have bully, victim, witnesses, and defender. Okay, as you see here, a student role in experimental group in pre, okay, they are very little compared with this control group. In the post also, it seems like bully behavior, okay, is very, it's like zero, okay, in experimental group. When we go for the victim, okay, in the pre-assessment, we'll find that it's 29.8, decreased to 26.8, compared with the post is like 7.1. Compared with control group 4.2. Okay, and witnesses as someone who witnessed about the behavior who saw, we find that it starts with 42.9 in the experimental group, compared with 33.8 in control group. In the post, it decreased for 31, while for the control group also decreased for 28. Okay, in the pre, as a defender, okay, we find that experimental group 25, compared with 28.2 in the post. Okay, we find that it's very surprising. We see that both groups, they are increasing. And regarding the defender, we find that this people in experimental group, okay, they have 61.9, while control group 64.8, okay, in the post. The interpretation behind this, the same student taken from the same class, okay, and I think students, they tell each other what happened, and I remember when we conduct our program, a lot of the students came to the class and to the venue. We conducted this program, and they asked, we need to continue how to do this program for us. So I think that some contamination happened during the data collection for the control group. If we go for the total knowledge scale, score or communication skills and attitude, and we'll find that there is a significant difference between experimental and control group regarding the total knowledge, total attitude. Okay, except for total empathy, there is no significant difference between pre and post regarding experimental group. Okay, while there is a significant difference in this control group between pre and post. Here's the communication attitude, ability to intervene in the post assessment. They start with inadequate knowledge compared with 38. Now they are adequate. 83 reported in experimental group compared with 62. Incompetent in communication skills, 20.8 compared with 19.7 in control. Reaching for competent, 79.8 in experimental compared with 80.3. Negative attitude, okay, compared with positive in post, and it's very clear in it, it's like 70.2. Also ability to intervene, okay, to start with very low, which is unable, okay, reaching for this 79.8 in ability to do intervention with bullet 1. A comparison between experimental and control regarding empathy. Here, there is also an effective empathy, cognitive empathy, and total empathy. We find that study domain here in experimental group, there is a change in pre and post. Okay, and as informed, there is no significant difference, while this significant difference was reported only between control group pre and post. In conclusion, okay, the training prevention program implemented in the experimental group showed a significant improvement in knowledge score compared to the pre-test. Control group also demonstrated an increase in knowledge score, although not as substantial as the experimental group. There is increase, but it's not like this increase. And as I told that, because they are in the same school, the same class, so we believe that maybe, and many of them, they been exposed. I think the majority of the control, a big number of control, okay, were faced by bullying behavior by their classmate, as well as a big number of them also attending previously workshop held in the school, and this is why I think that control group having their knowledge score increased in post. There were no significant difference in affective emotional empathy, cognitive emotional empathy, and total empathy score between pre-test, post-test of the experimental. In contrast, control group exhibit significant difference in empathy measured between pre and post-test. Student training is an essential, so recommendation here, we believe that student training is an essential aspect of delivering this program to students in school, since they are vulnerable individuals, and training them is a key to success. And we ask the school to develop a policy called no bullying and no prejudice, okay, should be implemented in all schools as a law for protecting our children from the harm. And this punishment law should be developed or should be governed by all and all harmful behavior affecting the safety of our children should be, it's like when you give like positive reinforcement, you have to give this negative reinforcement just to teach our students that and all of us who are equal, okay, no prejudice, no bullying should be done inside the school. And this is a barcode for my reference. And we have to say for bullied children, a message, which is, please stop bullying. And this is my data. And if you wish to contact me, and if you have any question, thanks so much.
Yes, any questions?
If you have any question.
Yes, any questions to Dr. Amal? Just if you have any questions related to this topic, you can text in chat box or we'll be asking behalf of you, even after the completion of the Congress.
Okay. Thank you so much.
Yes, thank you so much, madam, for joining this event. Hope we expect your presence for next time in face-to-face meeting. This time we are planning in Valencia, Spain. In next
I
year.
wish I wish to attend. يعني always I attended many conferences in USA, but yeah, okay, maybe next year, inshallah.
Yes,
Okay,
yes, thank you so
so
much.
much. Thank you.
Yes.
Thank you.
Yes, next we asked Dr. Siham Elgil from King's South Hind, Abdul Hazil for Health Sciences from Saudi Arabia.
Hi, everyone. My name is, my voice is clear?
Yes, it's fine, madam.
Yeah. My name is Dr. Siham El Gamal. I'm Egyptian and I'm working in Saudi Arabia as assistant professor, College of Nursing, King Saud ibn Abdulaziz University for Health Sciences. And actually, we can say that in the patient education is one of the nurse's role and is very important, especially for the patients. Those require prolonged treatment and they need to be compliant for long-term therapy for decreasing their complication and increasing their compliance and decreasing their stay in the hospital. So our research is, my research is with title Impact of a Designed Nursing Intervention Protocol about preoperative liver transplantation care on patients' outcome. طبعا patient's outcome here, we mean it by it the occurrence of certain complication post-surgery and the length of hospital stay during the patient hospitalization, and this is study done in a university hospital in Egypt. So as you know, liver transplantation represents the only chance of cure and long-term survival as a treatment of irreversible liver disease and acute liver failure. And this rate of success and survival increased from 30% in 1970 to almost 80% currently. Liver transplantation is a complex surgery. It's not as usual or simple surgery, which require removal of a diseased or injured liver and replacement with a healthy whole liver or a segment from a liver from another person called donor. Liver transplantation surgery is major and causes more complications than any conventional surgery. So the recognition and the management and prevention of this complication and the comorbidity after the transplant is the key to improve long-term outcome. This complication could be post-surgical like hemorrhage, anastomotic problem, or non-surgical like a rejection, pulmonary impairment, renal impairment, infection, cardiovascular disease, diabetes, which is associated with the complexity of the surgery itself and the disease process, as well as the medications the patient take to reduce their immunity or preventing rejection. Therefore, it's important for liver transplantation patients and their families to understand the basic process involved with liver transplant, to appreciate some of the challenges and complications that they are facing, and to recognize symptoms that should alert the recipient to seek medical help. And studies have shown that in a preoperative teaching reduces the patient anxiety, a post-operative complication, increasing the patient's satisfaction with the surgical experience, enhancing the adherence to the treatment plan, and facilitate a return to normal life. So the aim of our study is to evaluate the impact of a designed nursing intervention protocol about the preoperative liver transplantation care on patients' outcome at a university hospital in Egypt. The research hypothesis where the patient undergoing liver transplantation who will be exposed to the intervention protocol will show better outcome in regard to their knowledge and practice score, as well as the occurrence of certain complication and the hospital stay. Quasi-experimental research design was utilized to conduct this study because we used a convenient sample, so we didn't randomize our sample, so we used this design. The subject for on 1 year, a convenience sample including all the adult male and female patients scheduled for liver transplantation invited to participate in our study. Inclusion criteria: able to communicate and have intact senses like hearing and vision. Exclusion criteria: smoker, which were excluded from the study. This study done in a liver transplantation unit at Al Manial University Hospital, Cairo University. Before conducting this study, we spent enough time in the unit, liver transplantation unit itself, to assess the needs, the educational needs for those patients, what we need to put in our program, which including some information about the disease itself, about the surgery, information also about what is the complication will happen for them. Even the visitation rules is included in our program. In addition to follow up for the patient post-surgery for the complication and their compliance to practice breathing and coughing exercises. In addition, we added information about the complication like rejection, hemorrhage, and the most important part here also the information about the medication, what is the dose and how many times they need to take, and what is the name of the medication, and what is the nursing intervention or assessment should be done before and after taking this medication, as well as some practice for breathing and coughing exercises using spirometer, range of motion exercise, walking, and how to return to social. This protocol developed and revised by experts in the field, and then it's developed by English language, and then it's translated into Arabic and done in booklet to be given to the patient to be with them also. Then we formulated 4 tools to collect data from the patient and to assess a hypothesis, research hypothesis. The first tool is socio-demographic and the medical data, which include the patient demographic data like age, sex, educational level, marital status, and the medical data like diagnosis the patient admitted with. Then we have pre-post knowledge assessment questionnaire and observational checklist, which is done to assess pre and post practice skills like coughing, breathing exercise, or range of motion, and then follow up monitoring sheet to monitor the occurrence of complication post liver transplant surgery. The data analyzed using the SPSS software. For this study, before starting data collection, we get the official permission to conduct a study from the Vice Dean of Higher Education and Research Directors of Critical Care Units at Al Manial University Hospital. And we took a patient agreement by signing a consent form after explaining the nature and the purpose of the study. And each subject informed that they have the freedom to participate or to leave the study whenever they want, in addition to ensuring the confidentiality for each subject information. The result, some of the socio-demographic data, the majority number of patients were 14, total number of the study sample, but we faced 3 deaths during the study with attrition rate 21%, and the majority of the subject, almost 90% were male and 1 female. And the age, more than 50%, as you see here, were between 40 to 50 years old. As regard to their educational level, 54.5% have university education, highly educated. And as regard to their diagnosis, the majority having liver cirrhosis, as shown in this pie chart. Also, as regard to the length of hospital stay, 60% stayed in the hospital around 11 to 20 days post-surgery. This table show assessment items as regard to knowledge about the liver function, knowledge about the liver transplantation, patient monitoring and post-operative and after return to home, visiting rules, knowledge about the nutrition, what they need to eat and what they need to avoid, knowledge about the medication, immunosuppressant medication, and knowledge about respiratory exercise and range of motion. And we assessed the patient pre and post knowledge, عملنا questionnaire, and each one item is correct to get one score. So when we make TA test, we find in a few significant difference in all the item pre and post as regard to the total knowledge and subtotal. As regard also to their practice before implementation of the protocol and after implementation, also we find that they have a significant difference in their level of the practice for deep breathing exercising, coughing exercising using spirometer, upper and lower range of motion exercises, with the total and subtotal score have a significant difference. Unfortunately, as regard the complication, because we have less number of the patient, and this is one of our limitation in the study, we have only 11 patients, and we compared the occurrence of complication in those patients and compared this complication to retrospective groups. We assessed the patient files for 3 years before starting data collection for our study. And we find, as you see, in pleural effusion occurred in 5 patients with percent of 45.5% compared to 20 patients in the retrospective, اللي هي 38.4%. As regard the lower limb problem and the wound complication, as well as a rejection, pressure ulcer, and ascites, we found that in one patient only developed rejection with 9.1%, and also one patient in the retrospective with percent 1.9. For retrospective, we have pressure ulcer in 3 patients with 5.7%, and 5 patients developed ascites with 9.6%. In conclusion, we can say that based on the result of this study, we can conclude that the patients who were exposed to the nursing intervention protocol showed significant improvement in their knowledge and the practice score in different breathing, coughing, and range of motion exercises. And this improvement was manifested in their post-total mean knowledge score and post-total mean practice score. In addition to the complication didn't differ throughout the study period compared to the retrospective findings. In recommendation, all the patients scheduled for liver transplantation and their families are in need for adequate knowledge and skills necessary to helping them to adapt to their life after transplantation. Establishment of website including all information pertaining to the transplantation process and all aspects of health education, such as different educational material, media, and audiovisual, and this website should be specified to the patient undergoing liver transplantation surgery. For further studies, they must be carried out in order to assess nurses' knowledge and practice regarding to the care of organ transplantation patients, and the replication of the study on large probability samples selected from different geographical area is recommended to obtain more generalizable data. This is a sample of our references, apart from the references we used in the study. And this is my contact, and thank you for your time and for your attention to my presentation.
Yes. This is the presentation from Dr. Sehem El-Gamal. Any questions regarding this topic? I think there is no questions, madam. Thank you so much, madam, for presenting this, your talk in this Congress. Hope we expect your presence for next face-to-face meeting next year. And you will be getting the participant certificate within a couple of days. Thank you so much once again. Next we asked Dr. Beth, one student from Southern New Hampshire University from USA. The topic will be generations different using the diversity to your team's advantage.
Good afternoon. Can you hear me and see my screen?
Yes, it's fine.
Wonderful. I am happy to be with you today, and this is a little bit different presentation, kind of changing the pace up a little bit, and I'm looking at generational differences and how you can use these differences in an advantage to your team. And this team could be a team of educators, could be a team of students. So it's a different way of looking at a group of people and helping to reach collective goals. So we'll look at the objectives for today. We're looking at the 5 generations that are currently working in healthcare in the United States and the benefits of each. And I would encourage you to look at the generations in your country that are working and evaluate those benefits as well, as the information would apply similarly. And then develop strategies to manage gaps between generations. And you'll see a lot of this on social media, where you'll see different generations almost making fun of a different generation than their own. So it's important that we think about, what is a generation and why does it matter? So a generation is an illusion of unity that's present with individuals of similar ages. And age is the most common form of diversity in the workplace. So we're going to have lots of people of different ages. So it's important that we be able to work with all those groups through realizing the benefits of each. We need a more culturally competent workforce, and 1/3 of employees waste 5 hours per week on chronic unaddressed intergenerational conflict. So when we can bring different generations together with an understanding of where each is coming from, then we're going to have less intergenerational tension and fewer communication breakdowns. So that's why it's important. So in the United States, if we look at generations, folks born between 1929 and 1945, they are called the traditionalists or the silent generation. And so this is very much rooted in World War II. And these folks tend to adhere to rules. They're very dedicated to their employer. They tend to stay with one employer for as long as they can. Less questioning of authority, very hardworking, and they are very trusting in hierarchy and have a linear work style. When we look at the next generation, individuals who were born from 1946 to 1964, this is referred to as the baby boomer generation. And these folks are quite different in that they question everything. So our first group was very much trusting and not likely to question. These folks are going to challenge authority. They believe anything is possible. They see their generation and their work as being transformational. And these folks, their work is their central focus. They live to work. The third generation that's currently in the workforce are people who were born from 1965 to 1982, known as Generation X. And these folks are known for being entrepreneurs. They're highly educated. They see themselves as free agents in that they will want to get out into the world, see what's out there that is going to make their life better. And these folks, in contrast, they work enough to provide for the lifestyle that they want to have. And some will say that they also have a strong sense of what's due to them or sense of entitlement. Now, when we look at the next generation in the United States workforce, these folks were born from 1983 to the year 2000, and this is known as the millennial generation, first described as me on the Time magazine article displayed here. They want what they want and they want it now. This is the generation that grew up as children where everyone received some type of participation award, and you may hear it referred to as everyone gets a trophy. These folks are extremely tech savvy and they are fiercely independent. And then Generation Z is the final generation that we see in the United States, and born from 2001 2015. And they are known for instant gratification. They are not only savvy with technology, technology is their life. That is what runs their life, and they can't imagine functioning without it because they've never known life without technology. They connect digitally in every way. They are multitaskers, and they are designed for careers that do not even exist today. So let's transition into how does each generation view life? The traditionalists look at the life as being, you should be grateful you have a job. The baby boomers, they want something better. So they're striving in a positive way. Generation X is more realistic. Millennials, they see life as for their picking. It's like a cafeteria. We're going through and we're selecting what we want for our life. And Generation Z is very much represented by I'm coping and hoping. Somewhat a little bit depressed, concerned about what the future holds for them, because they're the youngest and they feel that they're being left with many issues such as climate change and war to cope with. The traditionalists, when they look at the future, they're seeking to stabilize the future. The baby boomers, they're still wanting to create the future. Generation X, they're skeptical about the future. And millennials are recognized by the acronym YOLO, you only live once. So they're wanting to go out and make their way and do it in a significant fashion once. And Generation Z is the acronym FOMO, fear of missing out. They have the fear that all things won't be available to them. So let's transition to talking about the values and talents of each generation. So we've talked about how the generations look at this information in a different way. Let's talk about the value and talents of each generation. The traditionalists, they're the folks who have tremendous amount of stability and knowledge, simplicity, gratitude, contentment. So they're a great stabilizing force for our teams. That's the person that you may want to talk with ahead of time when you know you're presenting change to your team, so that they can support you in that change, because they will be the stabilizing force. The value of the baby boomer generation is that they have significant life experiences. They're aware of where potential problems or pitfalls might be, and they're great life coaches. So we want to draw on their experiences that are significant. Generation X, they have tremendous value as well. They're very much realists. They have a very pragmatic approach. They're seeking balance. They're very resourceful. So we want to use those talents in our teams. With our millennials, they're full of energy. Okay, they're full of energy, confidence. You know, they have no concept that something might be hard for them. They're tech savvy. They have all these social connections, and they're optimistic. So we absolutely want to draw on that energy to support our teams. Generation Z, they have a hacker mindset. How can I get this done? Maybe I won't be able to get done everything that I want to get done, but I can cut this time off and I can get enough of it done that it meets the goals. And so they have that hacker mindset in a good way. They're very much cause-oriented and want to do good in their world. And they give us such a fresh view because of their age. So I would encourage you to just pause for we'll pause for 15 seconds and think about the generational differences that you see in your teams. And again, this could be a team of individuals who are in nursing education, or perhaps it's the cohort of students that you have, or some other team where you volunteer. So what are the generational differences, and what are the dangers if we're not valuing those gifts? So we'll transition to how do we manage this gap? I mean, the gap is very clear in these 5 generations. So how do we work with that? Because each generation has something to offer. Culture and technology has shifted and changed how we work, changed how we learn. And so our shared experiences are either a unique contribution or a unique conflict. So when we as leaders look at it in this way, that we can take these teams and we can have a unique contribution or we can have a unique conflict, we're making a very definite choice to move towards contribution. So I would encourage people, if you are if you are a traditionalist, you're one of our older folks, born between 1929 and 1945, to think about when was the last time you tried something new? And do you care for your team members' differences? Are you valuing what these other generations bring to the team? Are you welcoming new ideas from people who have less experience? And can you see disruption as an introduction to something new instead of an interruption? And boy, that's a really profound thought to think about. Okay, this person's not bringing a disruption to me. It is an introduction to an interruption. So that's a significant shift in thought. If you're a baby boomer, and I am a baby boomer, You think about these folks they've contributed a lot of experience that informs our work today. They have a lot of life experience. They're great mentors. We need to be using them as mentors. They have an awareness of what to avoid. As baby boomers, we need to recognize what younger team members think. They're literally begging us to ask them what they think. What's their opinion? They want to be recognized where their thoughts, what are they thinking? What do they see as a solution? Younger generations hate the phrase, pay your dues. In other words, you should be much older, much wiser, have much more experience before your opinion matters. Younger team members think, gosh, this company takes forever to make decisions. And they have no idea how stressed out I am. And many younger generations are thinking, I will stay as long as I know I'm making a difference. So it's important that we are really cued into what our younger team members are thinking. If you're a baby boomer, here's what younger team members need from you. Those younger team members need to learn how to do the job, and they need to be learning the soft skills, how to communicate, how to read the room, how to read people, how to problem solve and serve people. We often refer to the 3 R's of reading, writing, and arithmetic, but they need to be learning resourcefulness and resilience. And baby boomers can help young team members know how to blend into a group, become one of the team, but then also know how to stand out and how to showcase their good ideas, but not demand that everyone adjusts to them. And this is such an important skill. Younger team members may be afraid to speak up in a group, and they don't know how to approach it, and they can be off-putting to other team members. So suggest to them how to make themselves seen and heard effectively in a group setting. So Generation X, what do they contribute? They are contributing realism, a pragmatic approach, a balance, and they're very resourceful. So what can they contribute to the younger team members? They can provide direction because they are closer in age, because these folks were born between 1965 and 1982. The younger generations are more likely to be watching what Generation X is doing. So Generation X wants to model how to carry yourself in meetings, how to present yourself in emails. But the younger generation will respond from Gen Xers when Gen Xers present it as a story, not a lecture. Younger team members need to know the big picture and the long term. So when we're telling that story, we want to emphasize those two pieces. And Generation X can teach younger team members how to read nuances and how to put out fires with water rather than gasoline. So how do the younger folks be effective without being inflammatory? Our millennials that were born between 1983 and 2000, so they're the ones with all that confidence and energy, and they have great social skills, and they're optimistic. So we can help. If you're a millennial, you can help younger team members by leading with empathy and understanding, but being willing to tell them the truth in a gracious way. Be sure and explain why we're doing certain tasks. Millennials should be offered consistent feedback and offer competitions among peers. Anytime we can gamify work, that's a great way to get involvement from younger team members. We want to make sure we're creating safe spaces where younger team members can ask questions, and be sure and celebrate successes. We often work so hard to get to a success and then we move on to that next project. Millennials can be most effective when they're mentoring rather than managing. So Generation Z, our youngest generation in the workforce, born between 2001 and 2015. So remember their contributions, that hacker mindset, that do-it-yourself disposition, all that social media savvy. We want to be supportive of this youngest generation in the United States workforce by listening. Boy, think about that, that impact of listening on that individual, providing with them a sense of purpose. You know, why are we doing this particular project? It's a great opportunity for a young person coming into the workforce to put some short-term successes or wins under their belt so that they begin to feel good about themselves. We want to help the Generation Z to focus on one meaningful objective and get that completed. And that's going to help them get that first win under their belt so that they feel good about the direction they're moving in. Encourage simplicity because they put a lot of pressure on themselves. This generation feels a lot of pressure, and they internalize that pressure, and we see that in the increase in anxiety that younger generations feel. We need to be building relationships before they'll trust us. So again, I hope you'll jot down 2 to 3 areas where you feel like you can begin to mind this gap, bridge this gap to other generations. Here is my email address. I would love to hear from you. b.vanorsdale@snhu.edu. And I also want to tell you that the book that really encouraged me with learning more about age diversity is from Tim Elmore, A New Kind of Diversity. And that's from the Maxwell Leadership Group. So I wanted to share that with you. And then I don't receive any compensation for that. I just thoroughly have enjoyed the book, and we've done at Southern New Hampshire University, we've done quite a number of, we've done a couple book clubs, and we're going to be doing some other presentations on this, and have seen this as an opportunity to bring different generations together and use that to our advantage. So thank you for the opportunity to present to you today.
Yes, this was the presentation from Dr. Beth. Yes. Any questions regarding this topic? Any questions? If you have questions regarding this topic, just you can text in chat box. We'll be asking you on behalf of you, even after the completion of the Congress as well. Any questions? I think there's no questions, madam. Thank you so much for joining this event. Hope we expect your presence next year in face-to-face meeting that is going to happen in Valencia, Spain. And you'll be getting the participant certificate within a couple of days. Thank you so much once again.
Thank you.
Yes, have a nice day. Bye. Next, we asked Dr. Max Renault, Innovation in Global Precision Health Wealth Corneal Medicine from Qatar. Sir, if you are ready, you can start sharing your slide. Even we also request Dr. Thomas Udumo from Rocksteady, Aldrich Soto from Ontario from Canada. If you are ready with PowerPoint presentation, you can start sharing your slide as well, sir. We have 2 talks left for the Congress.
Okay, ready now, joining.
Yes, no problem, sir. Can I share from here or you'll be sharing from your side, sir?
Sorry?
Can I share your PowerPoint presentation or you'll be sharing?
No, I've revised it slightly, so let me use mine.
Okay, no problem. Yeah, it's fine.
Okay, are you seeing it?
Yes.
Okay, thank you. Okay, thank you and welcome to my presentation, everyone. My name is Thomas Udumo, and I am in Canada. So I have I'm a BCom CPA, and I have received the Prime Minister's commendation. My area is actually financial management, but I work closely with policy people. So I am also very conversant with policy work because we work hand in hand. I have 35 years of financial management experience. And in 2020, October, when COVID struck, then I retired and founded Rocksteady Holdings Canada Incorporated. So for this presentation, I acknowledge the support of my scientific advisor, Madame Amel Boumamra Tadleb, who is a telecoms engineer from Algeria Telecom. So I'll be covering a number of objectives here. Changes in nursing education and practice in the light of the nursing labor shortage, of which we have a serious one. And then also how evidence-based practice in nursing has affected the quality of nursing care here. And then I'll go into international collaboration, innovation in nursing education, patient-centered care, and then the government's role in facilitating change. Then I'll finish by briefly reviewing future trends in the practice and education on nursing in Canada. Yeah, so the big change that's hit the nursing profession in Canada, as everywhere else, has been the COVID, and it has seriously affected the profession. So a survey was done recently, and to look at, among others, 2 principal issues. One, it was whether the nurses have been asked to work in areas that are outside of their profession, and then correlated with that as to whether they received training in those new areas. So then a comparison was done with, well, internationally, and then also against one of our major competitors, Australia. So looking at whether the nurses were asked to do some jobs outside of their profession, compare internationally, we were at 27% of the nurses being asked to perform roles outside of their training. And internationally, it's 36%, but Australia seems like, well, it was lower than the international the requirement as well as the Canadian one. Then as to whether or not they were given training in those areas, about 30% of our nurses were given yes, but internationally, about half were given, which is much higher than us. And in Australia, it was 36%. So then correlated with that, because COVID is still continuing, even though it's not at the scale at which it was previously. But now there's a need to realign education for the nurses with the current situation. And correlated with that, there is still a commitment to preserve the quality of nursing education. And Canada is among the major industrialized countries that has significantly increased the uptake of internationally educated nurses. And this was a subject that I did a presentation on in London, UK in last August. Evidence-based practice in nursing has affected the quality of care. So overall, the quality of nursing has continued to increase, but there are still opportunities for improvement. It's still centered around safety, timeliness, effectiveness, efficiency, and equity and patient-centeredness. Funding is geared towards proven treatments, primary care, and embedding tools of improvement into practice. An example is in knee replacements. As I stated previously, well, although I'm a financial person, but I am also very conversant with the policy. And so I review policy from a financial management perspective. One of the major areas is in knee replacements, where cases have to be put for additional funding tied to outcomes in that specific area. So previously, funding was just allocated and to the provinces. And here, I also need to explain that in Canada, it's the federal government is responsible for health policy and funding, but the delivery of healthcare is the responsibility of the provinces. So in allocating funding to the provinces, the funding is tied increasingly to these procedures, specific procedures and timeline. Specific goals are tied to the funding. So let's look at international collaboration. Canada is one of the industrialized countries that is really connected internationally. And this began at very early 1908. And we have cooperation with quite a number of countries, including developing ones. And this in Africa, well, we have ties with countries in Africa and South and Central America. And Nigeria is one of the countries with which we have collaboration. So innovations in nursing education, these are mainly in 4 areas. One is advanced clinical practices. And two is greater simulation, where technology is used to practice how to carry out specific medical procedures, the care that relates to them. And of late, with the advances in technology, in digital technology, as well as in robotics, there's been funding allocated to the training of nurses in the applications of those technologies, as they are useful also in alleviating nursing the work. And also, lastly, there's been a continuing role in research in the various areas of nursing. And many patients are requested to sign permission to participate in those areas. So let's look at patient-centered care. And this is geared at promoting respectful, compassionate, culturally appropriate, and competent care responsive to the needs of the clients and their family members. So in Canada, this is also a particularity that is applicable to Canada. There are the First Nations. We have three groups of the population for which the federal government is responsible. The rest of the other citizens and permanent residents, it is the provincial and territorial governments that are responsible for delivering healthcare to them. But for these three specific groups, the delivery of healthcare is the responsibility of the federal government. One is the First Nations, two is the Innu, and three are the Métis nations. So, and this there are four concepts here under patient-centered care: treating people with respect, sharing of complete and unbiased information with the patients. Before the doctors and nurses merely carried out the procedures, but without explaining what they were and their implications to the patients or their families. Now there is a greater move towards sharing information with them. And then they are also more empowered in the decision making. And so after explanation to them, then they are requested to sign the paperwork. And also in policy work, even in the development of policy, there is greater participation of patients and their families. And that whenever major policy decisions are considered, then a consultative committee is struck and contributions are invited as part of the input process. So let's look at the government's role in facilitating change. Arising out of the consultative work, the government invited comments from all the stakeholders. And out of that, a nursing strategy was developed. So in total, there are 11 strategies, and these are organized into 4 themes. We'll not go into the strategies themselves. Now we'll only look at the 4 themes, which are unified action, improved data research and human resource planning, appropriate education, and improved development and retention strategies, because we are really we are so pressed for nursing labor that you won't believe it, that emergence of late, there are periodic closures of emergency rooms in emergency departments, I mean, in certain hospitals. So let's lastly look at the future trends in the practice and education of nurses. So because of the shortage of nurses, the nurse to population ratio is below the target level. So as well as encouraging the enrollment of more nurses within Canada, the government has also opened up the practice of the profession to more internationally educated nurses. Before, there were certain barriers which were policy based, but now those are being relaxed. So as opposed to before, where the nurses had to write the exams and qualify to be recognized nurses here in Canada, now they are even allowed to register provisionally as they pursue those studies. Then secondly, there are advances in the practice of the profession. And these are in the areas of management and information technology, among others. So there are more courses to upgrade the skill set of nurses in these additional areas. Then lastly, it's happening now that because, and I think I had, well, when I joined, I thought I had one of the nurses, maybe, well, I mean, one of the presenters, maybe from Egypt, talking about the pressure of on nurses at their workplaces. Here, because of the shortage of nurses, there is great pressure on them to do overtime, and they do unbelievable hours. And because of that, many are leaving the profession, because if they stay under the employment of the government, then they have to comply with the requirements of the job. And one of the major requirements of late has been mandated overtime. So now to respond to that and to achieve more family balance, they are more increasingly leaving the profession technically. And by that, I mean they go out, they resign, and then they form companies, nursing companies. And because the government is so hard pressed for nursing labor, then it's got no choice but to re-engage them, but not as employees, but as consultants. So that's the end of my presentation. And I'm glad to share my contacts here. So it's been a pleasure. I thank Inovine for inviting me. And I also thank my fellow presenters and the audience. Thank you very much.
Yes, thank you so much, sir, for joining this event.
You're welcome.
And I would inform that Dr. Thomas Moore is joining our conferences last 1 year. Thank you, sir, for supporting us and joining this Congress. And you'll be getting the participation certificate within a couple of days. Thank you so much once again.
Oh, you're welcome. Thank you.
Yes. Next, the last speaker of the session is Dr. Yes, Dr. Max Renaud from Innovations of in Global Precision Health, Will Cornell from Medicine from Qatar. Yes, sir, you can go ahead by sharing your slide.
Yes. Hello, and thank you. Can you see my
Yes,
slides?
yes, sir. It's perfect.
Okay. All right. Perfect. Well, thank you for having me. My name is Max Renaud. I work at Weill Cornell Medicine. So today I wanted to speak to you about a study that I conducted a little while ago about how teams of nursing adapt to crises. And this is about emotions, and it's about the importance of leadership. So if you just take a couple of seconds and think about a crisis that you would have experienced at work, I'm sure as healthcare professionals and as nurses, there's a lot of those daily, weekly. So what do you recall about those type of crises, right? What were your emotions? What was going on? And so coming closer to home, I guess COVID-19 is something that's still very much alive. It's a crisis, undoubtedly. It's a pandemic that affected all of us globally. It's caused a lot of distress, a lot of anxiety to patients, to frontline workers, and hospitals in general, right? And so going into the study, it was this sort of question that we were trying to answer: is how do nursing teams adapt to crisis? And there's obviously a lot that we know about how teams adapt in general, whether these are kind of agile teams or just plain simple adaptation, right? So teams normally would coordinate their work, they'll do a lot of communication, they'll reconfigure on the fly, they'll restructure depending on what work needs to be done, and so on and so forth, right? So a lot of these things are known in the literature to result in speed, flexibility, and responsiveness. And you can kind of put these type of factors to being structural in nature or procedural, and mostly cognitive in nature, right? But what I was interested in is what is at the bottom of this iceberg here, which is really the role of affect and emotions. And in fact, we don't know that much about how teams adapt in crisis situations because they're not typically studied as much. Right, so to answer this kind of question of how nursing teams adapt during crisis, so I used to work at a pediatric and women's hospital in Doha, in Qatar, and so I investigated nursing teams that underwent a number of consecutive crises. So starting with hospital floods in 2018. So we're talking torrential floods, first time ever seen in the country of Qatar. So the infrastructure couldn't cope. So the hospital flooded severely. You could see pictures here of offices and the lobby and patient rooms, of course, that happened as well. And so these nursing teams then went on to experience various reorganization and restructuring things during 2019. And finally, the COVID-19 pandemic hit early or so 2020. So this is a qualitative longitudinal case study. So I selected 5 nursing teams that were deemed high in terms of their agility and adaptive performance, and 4 that were deemed low. It was actually the clinical nursing managers, who are the departmental managers, if you like, that selected those teams, or at least ranked those teams. And so I was able to select 5 high versus 4 low. And so it was a comparative case study. And we kind of followed these nursing teams as they experienced crises. So the first thing is that the data collection, we tried to get as much data as possible to triangulate to findings. So I conducted semi-structured interviews with nursing managers, nursing leaders, and nurses. So just kind of reminder, the structure is really that you have the nursing managers at the top that overlook a number of teams, and each one of those nursing teams of 6 or 7 nurses are looked after a clinical nurse leader. Okay. So then I did also observations of these morning huddles that the teams were having, trying to observe their team dynamics and the general climate in the team. Early during the COVID-19 pandemic, I also did a survey of emotions of nurses. And then I also tapped into the WhatsApp text messages of a high and a low agility team as well. And so all of this information was kind of coded recurringly, going through first order codes, second order codes, and then tying that back to the theory in the literature, and where codes didn't exist, really kind of came up with that in an emerging fashion. So the first thing to confirm is that nursing teams are indeed agile. So most of you are probably familiar somewhat with the agile type of principles and framework. It's really a manner to get teams to do work and organize work which is in dynamic changing environments. So it involves a lot of self-organization. So the nurses in the study were really self-organized. They were empowered by their nursing team leaders to just get on with the work daily, and only had to go back when they faced kind of big issues that they couldn't solve themselves. They conducted these daily huddles every morning, where they would talk about the patients that they would normally see on that day, any foreseen issues, and so forth. They had wall charts where they kind of looked after the key tasks, key improvement initiatives they had. They also celebrated successes on these wall charts as well. Then they conducted a lot of retrospectives and reflection exercises. This happened actually during the daily huddles as well. So what did we learn from yesterday that we might want to bring into today? And also at the end of each week, kind of thinking about what went well, what didn't go so well, and try to learn from that. They also buddied nurses up. So a junior nurse would be shadowing a more senior nurse and trying to learn on the job through somebody more experienced. And finally, all these teams were extremely customer centric, and customer here, of course, is the patient, right? So all of the work that was being done was really for the benefit of the patient, you know, for the care, the quality care that they were providing to the patient. So this is all fine and well. So all these nursing teams in the study, all 9 of them were truly agile by these agile framework standards. So they were following these type of procedures and organizing manners of doing things. But as you'd expect, crises are actually extremely emotional events, and they're experienced differently in teams. So the first insight there was that negative emotions were felt about the same, no matter which team these individual nurses were in, right? So that's fine. But where it did matter was that the high-performing teams, so these 5 high-performing agile teams, seem to have a lot more positive affective tone in their team exchanges, in their communications. And this was extremely vivid in the WhatsApp text messages, where, you know, because I was able to kind of code for affective tone and really looking at things like feeling proud, active, alert, strong, and so forth. So there was already a pretty big difference in the way emotions transpired inside the teams at the team aggregate level. Now, the second insight is that now these emotions that are triggered by the crisis then get on to trigger an adaptation cycle, which is extremely emotional in nature. And let me show you what that looked like. So a distressed nurse during a crisis would seek help from her teammates, right? And then if she was lucky enough to be in one of these affective, emotional teams with high agility, then she would actually get that help back, right? So comfort-based help seeking, which resulted in compassionate help giving. And this was prominent in those high performance teams. Then repeated cycles of help then led to these concepts of care and camaraderie at the team level, where care was a supportive, psychologically safe environment for the team, where the well-being of nurses was really being looked at. And camaraderie being this concept of extreme cohesion and familial effect. So this is loyalty to the team, we're one, we're in this together kind of thing. And the interesting thing, because it was a longitudinal case study, was that the more help seeking that happened, the more care and camaraderie resulted. And then you had these feedback loops over time. And essentially these adaptation cycles that were very effective in nature resulted in being buffers, if you like. So teams that were doing these things well today, we found that they were much more likely to adapt to subsequent crises successfully. The third insight is emotions actually do need to be managed. So beware of unmanaged emotions. So this, there was something that was very interesting that was happening is that cliques or subgroups were being formed. And what we know about cliques is usually they form around demographics, culture, language, age, maybe things like that. But actually emotions, negative emotions were a trigger for cliques to get together and start forming. And the problem is that cliques or subgroups tend to disintegrate the team processes and the team dynamics. And that matters during the crisis because you need your nursing teams to come together and deal with things. And then the other important thing that was happening is that these highly effective agile teams seem to have leaders that recalibrated actively the negative emotions of these individual nurses, as we've seen, into more positive team experiences. And this, of course, went with a lot of counseling and reassurance and kind of a bit of fun. And so this was a very important differential between the low agility teams and the high agility teams. So what did effective leaders do specifically? So they grasped the individual emotions of nurses. So, and just recognizing that every person is unique. The way they would feel that day, their personal circumstances, whatever was going on, these nurses would feel different emotions, right? And so these leaders would proactively work to recalibrate these negative emotions into a more positive team state. They also worked hard to meet their team's emotional needs. They were thanking and praising on a daily basis, which was not happening in the other teams. And then, of course, they were identifying proactively these emotion-based cliques or subgroups, and they were just not allowing them to fester, right? Because at the end of the day, again, these sort of things would tend to break down the team process when they were under pressure. So if we try to look at a model of adaptation of what these nurses were going through, so we have a beautiful crazy zombie there as the next crisis potentially, hopefully not. And so a crisis leads to negative emotions at the individual level, but then these agile teams that were able to go through these help, care, and camaraderie cycles of effective adaptation cycles were much more effective and much more responsive to the crisis. The other thing that was happening was that the negative emotions were leading to cliques being formed, but the impact of that effective leader that would proactively dispel those cliques and work hard to convert negative emotions into more positive team states made all the difference. Right, so if you actually have a look at the paper, which I actually forgot to mention at the beginning, this is mostly based on a paper that I just published in the California Management Review. And on my last slide, you'll see a QR code of that if you're interested to have a read. So I won't go through this now, but there's a bunch of managerial recommendations there. For example, keeping a regular pulse on your members' emotions through meetings, their reports, or even kind of doing spot surveys on emotions. And it's really important to recognize that is an important thing to do. And then regularly socializing with the team, helping kind of build trusting relationships, team building exercises, and those type of things. So I encourage you to read this paper if you're interested to know a little bit more. So the contributions are really across these three big themes. Team emotions matter, right? Because crises tend to be negative events. But the important thing is that through the right interventions and types of leadership, you can turn these things into more positive events. Unmanaged emotions are a problem, so don't let those fester. In terms of adaptation, what we normally think of adaptation is primarily a structural, cognitive, and procedural process in teams. But we've shown here that it's under crisis circumstances, more importantly, it is an emotion-based process. And the more effective adaptation you're able to do, the better you are in building those buffers. Think about it as a bank account that you're saving into, right? So when the next crisis hits, you have those resources to deploy, emotionally speaking, in the teams. And then the importance of leaders who are very emotion understanding. and who try to recalibrate the emotions of their teams. So what I want to say is if you want to remember anything as directors, as managers, as nurses, healthcare professionals, is just really regularly keep pulse on emotions. Even between fellow nurses, it's important to just kind of know what's going on with people. Try to recalibrate things into something a little bit more positive. Negative emotions are absolutely fine, and people will have them, and it's important to recognize that, but don't let negativity fester, right? Try to create this safe, warm, helpful social context where your people can thrive and feel content and safe in. And then don't allow these cliques to fester, right? So if anything, to remember today is just value emotions, please, in your teams. That's really paramount. And so with that, I'd like to thank you and maybe leave you with a couple of quotes here. The first one on the left-hand side is something that a nurse told me during an interview, which I'll read out to you. I'm on the verge of having my meltdown. It will hit so hard because I know I'm not feeling well. I want to cry all the time. And with COVID, I come to work with this feeling that I want to slap the shit out of everybody I encounter. These are very powerful negative feelings, but that was the reality of what was going on during COVID. And then on the right-hand side, a fantastic manager that I've interviewed and participated in the study that I learned personally so much from. So we need to acknowledge that the process of grieving when change happens, it will affect people differently, and we need to support each other in this. So with this, thank you very much. I hope you found this useful. If you want to read the paper, there's the QR code at the top. And then if you want to connect on LinkedIn, please scan the code at the bottom. Thank you very much. And I hope you have some questions for me.
Yes, any questions? If you have any questions regarding this topic, just you can text in chat box, so that you can ask now. Any questions?
Awesome.
I think only 5 members are left for this event, sir. Already, as soon as they're completing, they are leaving the meeting room.
No problem. Thank you very much.
Yes, thank you so much, sir. You'll be getting the participation certificate within a couple of days. Hope we expect your presence next year in face-to-face meeting as a keynote speaker for the Congress. The Congress is going to happen in Valencia, Spain in the month of June. Thank you so much once again, sir. And
thank you.
So, if you go to vote of thanks, we take this opportunity to extend our most sincere for the moderator, one who organized the event yesterday, keynote speakers, plenary speakers, workshops, students, delegates, general collaborators, media partners who have joined from different parts of the world for the support and cooperation. We also express our gratitude to sessions chairs, especially Holly Max for the co-chair for yesterday's for minute-to-minute guidance and support, and for providing encouragement at every point of the organization for this event. Let us thank speakers who have responded so well to our invitation to participate in the conference. We have received several papers which will form the basis of our discussion in the various sessions. Let us thank you all the associating with this conference by your presence. An event of this dimension cannot happen overnight. It requires meticulous planning and execution, an eye for the details. We thank everyone for the involvement they have shown and willingness to participate in this Congress. I'm especially thanks to Mr. Henry for his continuous effort in putting us together on one platform. Thank you so much once again. You will be getting the participation certificate as well as book proceeding booklet within a couple of days. Thank you so much once again. If you have any questions, you can do it. You can mail us. We'll be sharing our alternate email ID regarding this conference or topics that we are having. So this is our email ID. Just you can have. Thank you so much.